Good evening, friends. Challenges in managing lymphomas in 2022 with 15 international guest speakers. This webinar was fantastic. It began on Sunday and today is the last day. These are the 15 distinguished faculty of this webinar, and you have witnessed 12 of them already, and what wonderful academic exercise we had. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS, and the whole of webinar is supported single-handed by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, Yash Kalpesh and their team from Perfect Square, Executive Committee of Mumbai Hematology Group, all our faculty members who are extremely prominent leaders in their fields, all our discussants who are eminent hematologists and medical oncologists from India, new participants who are sparing your Thursday evening, or morning or afternoon, depending upon from which country you're logged in. We have registration from 27 countries, and I thank all of you for taking interest in this academic exercise. Do visit the website of Mumbai Hematology Group. It's simple to remember, www.mhg for Mumbai Hematology Group India.com, and there is no password. You can access all our academic activities on this website. So today is the last day, day 5. We have 3 lectures. First on the CAR-T therapy, second on the liquid biopsy, and third on Hodgkin lymphoma. It's my pleasure to introduce our first guest speaker this evening, Dr. Paolo Stratti from MD Anderson, Houston, US. He's Assistant Professor, Term Tenure Track, Department of Lymphoma and Myeloma, Department of Translational Molecular Pathology at the University of Texas, MD Anderson Cancer Center, Houston. He is currently Assistant Professor, Term Tenure Track in the Department of Lymphoma and Myeloma with joint appointment in the Department of Translational Molecular Pathology. He is also the Clinical Director for the Lymphoma Tissue Bank, and previously he has served as Assistant Professor at the Mayo Clinic, Rochester. He earned his medical degree, cum laude, from the San Raffaele University of Milan in 2008, and he completed his internal medicine residency at the same institution and subsequently at the Mayo Clinic, Rochester. He's completed a Hematology Oncology Fellowship at MD Anderson, a Leukemia and Lymphoma Fellowship at MD Anderson, and a Malignant Hematology Fellowship at Barts Cancer Institute, London. He is internationally recognized expert in the field of immunotherapy and cellular therapy for the treatment of B-cell lymphoma, and is the principal investigator of multiple clinical trials and translational projects related to this topic. He is author of several peer-reviewed manuscripts published in high-impact journals, including Blood, Lancet Hematology, and he is regularly invited to present his work at international scientific meetings, including the American Society of Hematology and American Society of Clinical Oncology conferences. In light of his research accomplishments, he has received multiple grants and awards, including the Lymphoma Research Foundation Career Development Award and the Conquer Cancer Foundation Young Investigator Award. He is committed to gain further insight into the biology of lymphoma immune microenvironment and to manipulate its components successfully in order to develop novel, effective therapies and to decrease the toxicity of treatment strategies already available to patients of B-cell lymphoma. Today, he is going to lecture on role of CAR-T therapy in lymphoma. I request him to take over.
Thank you so much, Dr. Agarwal, for this very kind of introduction. I will go ahead and share my screen. I'm very thrilled to be here today, and as you can see, today I will touch on the role of CAR T-cell therapy for patients with B-cell lymphoma. This is a brief outline of what my presentation will be today. I will first define what CAR T-cell therapy is and what the indications currently are in the United States. I will then describe the screening process and the apheresis procedures, but I will also briefly touch on manufacturing procedures and bridging strategies for these patients. We'll then talk about lymphodepleting chemo and infusion management, monitoring and management of toxicities associated with CAR T-cell therapy, efficacy evaluation, and finally, how we manage patients who unfortunately are either refractory of relapse after CAR T-cell therapy. Currently, there are three autologous anti-CD19 T-cell products approved in the United States for patients with relapsed or refractory large B-cell lymphoma who have already received 2 lines of systemic therapy. Axi-cel or Yescarta, that was approved by the FDA in 2017, Tisa-cel or Kymriah, approved in 2018, and Lisa-cel or Breyanzi, approved in 2021. As you can see, the indications are quite similar, with the only exception that Kymriah in the United States cannot currently be used for patients with relapsed refractory primary mediastinal B-cell lymphoma. More recently, 2 of these products, Axi-cel and Lisa-cel, have also been approved by the FDA based on results of randomized phase 3 studies for patients who relapse after 1 line of systemic therapy. However, the indications are quite different. Axi-cel is currently approved by the FDA only for patients who relapse within 12 months from frontline chemoimmunotherapy, whereas Lisa-cel can be used both for those, but also for patients who relapse beyond 12 months, as long as they are considered transplant ineligible. These 3 products, in terms of construct, look very similar, with a pretty much almost identical extracellular domain, of course, targeting CD19, and intracellular signaling domain. What makes them different is mainly the co-stimulatory domain, which is represented by CD28 for Axi-cel, and this is a very strong co-stimulatory domain, typically associated with a very high peak of proliferation and a relatively short duration of persistence, as compared to 4-1BB, which is instead the co-stimulatory domain for Kymriah and Breyanzi, which is instead associated with a lower peak of proliferation, but a longer duration of amplification of CAR T cells. One thing which is also important to emphasize is that the ratio of CD4 to CD8 CAR T cells in the infusion product is controlled for Breyanzi, and it's 1-to-1, whereas it's not really controlled. It can be very variable and heterogeneous for Axi-cel and for Tisa-cel. These are the pivotal studies that have brought to the FDA approval of these 3 products in the United States for patients who relapse after 2 lines of systemic therapy: Zuma-1 for Axi-cel, Juliet for Tisa-cel, and Transcend for Lisa-cel. As you can see, the efficacy is quite similar, with a cure rate close to 40% across all products, maybe slightly lower efficacy rates for Kymriah, as also demonstrated by results of the randomized phase 3 trials in second line. In terms of toxicity, cytokine release syndrome and immune cell-associated neurotoxicity syndrome, as expected based on the co-stimulatory domain, again, CD28 for Axi-cel, as compared to 4-1BB for Kymriah and Breyanzi, tend to be more frequent with Yescarta. However, the rate of severe persistent cytopenia is pretty much identical, close to 30% across all products. When it comes to patient screening and product selection, there are no currently formal international guidelines, and there's not really a universal consensus. So I need to make clear that what I'm discussing today is really our institutional common practice. Our preference is for patients who are deemed eligible for CAR T-cell therapy to have a good performance status through ECOG evaluation, usually ECOG PS of 0 or 1. And the reason for this is the real-world retrospective studies have very clearly demonstrated the patients who have a poor performance status, no matter whether it's due to lymphoma itself, they tend to have very poor outcomes, due mainly to very early CAR T-related mortality. So we always try, when possible, as a team, to select for CAR T-cell infusion those who have an ECOG PS of 0 or 1. Of course, patients are expected to have a good cardiac and respiratory function, and possibly also good counts, with a platelet count above 50 and an ANC above 1,000. We all know that in real world, this is not frequently possible, either due to bone marrow involvement, and in this case, usually these criteria are waived in case of also of low counts due to splenomegaly or cytokine-mediated mechanism. But if the persistent cytopenias are due to previous treatments, usually we try to have a discussion balancing risk and benefits with the patient before proceeding with the CAR T-cell treatment. As for creatinine clearance, our threshold is actually quite low, 30 ml per minute and above is tolerated. patients with previous CNS involvement can proceed with CAR T-cell treatment, though we prefer these patients not to have active disease at time of initiation of lymphodepleting chemo. And of course, patients need to be compliant because particularly after CAR T-cell infusion, there are several restrictions due to infectious risk and of course, risk of onset of CRS ICANS. So cooperation is really necessary at this stage. One point that remains unclear is what to do with patients who have chronic viral infections, such as hepatitis B, C, or HIV. And really, there's no currently universal consensus on this. In this regard, 3 years ago, we have published our experience with 3 patients with chronic hepatitis, either B or C, that were able to proceed with standard of care Axi-cell at our institution. As you can see, 2 patients with chronic hepatitis B and 1 patient with chronic hepatitis C, though none of them really had active disease, of course, at time of initiation of lymphodepleting chemo. Of interest, it's very important to emphasize that at time of CAR T-cell infusion, both patients with chronic hepatitis B were receiving antiviral prophylaxis with respectively entecavir and tenofovir. And what we were able to demonstrate is that CAR T-cell infusion was feasible. These patients didn't have significant toxicity after CAR T-cell infusion. And as long as they were continuing their antiviral prophylaxis in case of hepatitis B, or they were monitored with frequent LFT measurements in case of hepatitis C, they did quite well. Of interest, 1 of the 2 patients with chronic hepatitis B, against medical advice, 1 year after CAR T-cell infusion, while in CR, decided to stop entecavir, and these patients had a very significant HBV DNA reactivation. This is very important to highlight because we know that immunosuppression, as I will show more in detail toward the end of this presentation, can be very prolonged and persistent after lymphodepleting chemo. So antiviral prophylaxis needs to be continued for at least 1 year and based on CD4 count even longer. So once patients, based on this screening evaluation, are deemed eligible for CAR T cells, of course, the next step is to proceed with leukapheresis that our institution is typically managed by our stem cell transplant colleagues. We usually prefer, in order to make sure that the T cell fitness before apheresis may be as good as possible, not to use any corticosteroids for 7 days prior to collection, and no systemic therapy for 14 days. Typically, radiation therapy is allowed, and sometimes in cases where systemic therapy cannot be held, particularly when it comes to non-chemotherapy-based treatments that are not supposed to meaningfully affect either lymphocyte count or lymphocyte fitness, there can be some flexibility. After apheresis, of course, then the manufacturing process starts. As you all know, this is very variable based on the product that we select. Typically, the shortest manufacturing time is experienced in the United States with Axi-cell, and it's on average 17 days, but it can be as long as 4 weeks or longer for Kymriah and Breyanzi. During the time frame, a minority of patients can just be observed, but the majority, typically more than 60%, needs to be given some treatment. And we typically call bridging therapy exactly the therapy which is provided between leukapheresis and initiation of lymphodepleting chemo. There's no currently a standard bridging therapy, so it's really dealer choice selection. This could be chemotherapy, biological therapy, radiation therapy, of course, clinical trials. What we were able to demonstrate, and this is a very well-known phenomenon, is that, of course, patients who need bridging therapy are patients who tend to have overall a worse outcome because of need for bridging therapy is really a surrogate marker for a more aggressive disease. But the bridging modality that we select may meaningfully affect outcomes. And that's because the way the immune microenvironment is manipulated right before CAR T-cell infusion can influence meaningfully overall response rates and progression-free survival after CAR T-cell infusion. As you can see here, patients in our experience who receive radiation therapy that, as you know, can decrease, for example, regulatory T cells and can repolarize tumor-associated macrophages to a more anti-tumoral phenotype, seem to be and to do significantly better as compared to those who receive other systemic therapies such as corticosteroids, biological therapy, or chemotherapy. So this remains an active field of investigation. Trying to identify the ideal bridging therapy in these patients may meaningfully affect outcomes in patients with large B-cell lymphoma who receive CAR T-cell therapy. And that's because we know that decreasing tumor burden after bridging therapy, through bridging therapy before CAR T-cell infusion is very meaningful. Tumor burden is probably the strongest predictor of response to CAR T-cell therapy. And we could actually, through bridging therapy, try to push for very low tumor burden, as low as a complete remission before CAR T-cell infusion. This is now a scenario that we start to encounter in the United States more and more, where bridging therapies can become so effective that patients have no measurable disease before CAR T-cell infusion. There's some hypothetical concern that these patients may not have enough CD19 expression, the hence CAR T-cells may not work. But we have recently demonstrated that actually these patients who in CR proceed with CAR T-cell infusion potentially may actually do even better. So again, once again, trying to identify a biologically rational and effective bridging therapy may meaningfully change outcomes in these patients. Once bridging therapy is completed and the product is ready, of course, we proceed with lymphodepleting chemo. For axi-cel and for liso-cel, according to the USPI label, the lymphodepleting chemo is typically represented by cyclophosphamide and fludarabine. But for Kymriah, bendamustine is an alternative option. And these are given between day -5 and day either -4 or -3, based on the regimen that you pick. And if possible, we prefer to administer the product on day 0, but there's some flexibility up to 14 days after initiation of lymphodepleting chemo. So of course, the longer you wait, the less the product may be active. Now, the reason why lymphodepleting chemo is really crucial for the activity of CAR T-cell is the activity on the cytokine milieu. As you know, by providing lymphodepleting chemo and decreasing endogenous lymphocytes, there's an increase, as shown in the past by the NIH group, of endogenous interleukin-7 and interleukin-15 that will become available to autologous CAR T-cells and then favor their amplification. Recently, we have been able to demonstrate that the depth of variation of lymphocytes due to use of lymphodepleting chemo is meaningfully associated, of course, with use of bridging therapy. So those who have received bridging therapy before, they tend to have a shorter variation, and that we have called DLIX. And those who have a small DLIX tend to have a lower CR rates, but also a shorter progression-free survival. Of interest, what we noticed is that low DLIX was not really associated with meaningful change in interleukin-7 and interleukin-15. The cytokines that I mentioned before seem to really drive CAR T-cell amplification as a consequence of lymphodepleting chemo. But by performing single nucleotide polymorphism, we were able to observe that there were only 2 genes whose polymorphisms were associated with DLIX, and both of interest were relevant to macrophage biology. Now, this is very important. As you know, for the last year, there's been an international shortage in fludarabine. And so the big question has been whether there could be any alternative lymphodepleting strategies, including bendamustine. But also, as mentioned before, many times this patient may have very low counts. And so using chemotherapy as a lymphodepleting strategy may not be ideal. So it remains an active field of research trying to identify biological strategies. There may be strategies, in this case, targeting macrophage biology to potentially replace chemotherapy and potentially result in even better outcomes. Once lymphodepleting chemo is completed, based, of course, on the type of product that we selected, we try, if possible, at our institution to keep patients in the hospital for 7 days from day 0. For 3 days after day 7, we typically see the patients daily at our infusion center, and then twice a week in our outpatient fast track. Then on day 30, they get restaged. And in case of CR or PR, they will come back 2 months later on day 90. For the first 30 days after CAR T-cell infusion, our main goal is trying to monitor and manage toxicity. As you all know, cytokine release syndrome is one of the most common toxicity after any CAR T-cell product. And the way we manage it is typically supportive treatment for grade 1 CRS. We use tocilizumab, which is an anti-interleukin-6, only for those who have grade 2 or higher. and corticosteroids only for those who have grade 3 or higher. But we do use tocilizumab also for those who have grade 1, either if it's very early, like around day 1 or day 0, or if it persists for longer than 3 days, despite optimal supportive treatment. As for immune cell-associated neurotoxicity syndrome or ICANS, first of all, the definition has many times changed over the last few years. The most recent grading system that we now, I would say, very consistently and universally use is the ASTCT grading system. But the way we manage it is not as clever as CRS. Pretty much for any grade of ICANS, what we use are corticosteroids. And in some institutions, anti-seizure prophylaxis is also used. ICANS really remains the main, at this time, CAR-T-associated toxicity challenging point to still try to address through our research. We know that the median time to onset of ICANS based on our institutional experience is around 5 days, with a linear duration of 6 days. It's sometimes possible to predict who is going to develop high-grade ICANS, as these patients tend to have very high peak of serum ferritin or serum CRP and very low monocytes after CAR T-cell infusion. And once they develop ICANS, the neuroradiological findings can be very typical. The most common pattern that has also been described for patients with B-ALL who receive CAR T-cell therapy is an encephalitis-like pattern, followed by a stroke-like pattern, a leptomeningeal disease-like pattern, and a PRES-like pattern, though we don't fully understand what this neuroradiological pattern really mirror from a biological perspective. EEG almost universally will show diffuse slowing, sometimes focal slowing, but also epileptic-informed discharges and even non-convulsive status epilepticus can be observed in up to 15% of patients or higher. So it's really crucial to perform an EEG in all patients who have any grade of immune cell-associated neurotoxicity syndrome, because these patients may need anti-seizure treatment as opposed to just prophylaxis approaches. We know the high-grade ICANS, and this has been really a relatively new finding that now several groups are confirming, seem to be associated with shorter progression-free and overall survival. This is somehow surprising and maybe counterintuitive, because really both CRS and ICANS are supposed to be a surrogate for CAR T-cell activity. And as a matter of fact, multiple retrospective studies have shown that patients who have CRS, as expected, they tend to do actually better. So why do patients who have ICANS instead tend to do worse? One possible hypothesis is that it may not be the ICANS itself, because actually these patients don't die of neurotoxicity itself or still of progression, but the way we treat it. As I mentioned before, corticosteroids for CRS are used very rarely, only for the very rare cases of high-grade CRS, which are less than 5 to 7% of patients. But really, corticosteroids are the only treatment strategy that we currently have for any grade of neurotoxicity. And corticosteroids, of course, can affect CAR T-cell amplification and function. Of interest is not any use of corticosteroids. As you can see here, there's no significant difference in progression-free survival based on just use of corticosteroids per se. But it seems to be the dose, the duration, and the timing. So a very high dose, in our experience, more than 186 milligram of cumulative dexamethasone dose, prolonged duration longer than 7 days, and early initiation within the first 7 days. That, as you know, for axi-cell in particular, are really crucial for CAR T-cell amplification. Those seem to meaningfully affect progression-free survival. As for overall survival, really any dose seems to be, any use of corticosteroids seem to impact overall survival, independently from the dose, the duration, and the timing of initiation. Of interest, patients who receive corticosteroids actually seem to have a higher CAR T-cell amplification. This is somehow expected. Of course, patients who have a higher tumor burden, we know are more likely to develop neurotoxicity, and hence these patients have more CAR T-cell amplification and require corticosteroids. And this is also proven based on dose, duration, and timing. So we don't think that corticosteroids per se are able to affect CAR T-cell amplification, but most likely they hamper CAR T-cell function. Unfortunately, while we have qPCR and flow cytometry to follow very closely CAR T-cell amplification, we're still working on robust assays that we could use to assess CAR T-cell function and clinical practice after CAR T-cell infusion, but that's not yet universally available. So it seems like it may be very beneficial for our patients to develop a corticosteroid-sparing strategy. And one thing that we're trying to do, our and many other institutions in the United States, is to identify novel targets. We know that one cytokine, interleukin-1 beta, seems to be meaningfully increased in patients who develop neurotoxicity on clinical trials, but also in real-world practice. And of interest, interleukin-1 seems to increase and peak during a very specific time frame, which is the first 7 days after CAR T-cell infusion. This is relevant because this may be a window of opportunity to prophylactically target interleukin-1 and prevent rather than treat ICANS in patients that receive CAR T-cell therapy. We have further supported this with, by looking into the infusion product of patients who develop ICANS and identifying a macrophage-like population that had a gene expression profiling enriched with interleukin-1 pathways. So once again, targeting interleukin-1 really seems to be potentially beneficial to prevent neurotoxicity in these patients. Of interest, some preclinical models have demonstrated that by using anakinra, which is an interleukin-1 receptor antagonist currently approved by the FDA for the treatment of rheumatoid arthritis, may be effective to achieve this goal. Therefore, we have tried to use anakinra, and this has been published, to actually treat corticosteroid refractory neurotoxicity. And what we notice, as you can see here, is that it seems to be quite effective for the treatment of ICANS, but not as much for CRS. So really the biological pathway that seems to be meaningfully affected by use of anakinra are relevant only to or mainly to neurotoxicity. Of interest, as we were expecting based on preclinical data, patients who have very high CRP or ferritin or high LDH, so high tumor burden or inflammatory burden, don't seem to respond quite well to anakinra, further demonstrating that we should probably try to target interleukin-1 earlier, the first 7 days, when interleukin-1 is still peaking and is not yet translated into a full-blown clinical picture of neurotoxicity. We are currently trying to do this. We have developed at MD Anderson and some other institution an investigator-initiated trial using anakinra as a prophylactic strategy during the first 7 days after axi-cell infusion. The study is actually now completed, and we hope to be able to share with you our final analysis at upcoming ASH. One final toxicity that is still representing a major challenge for these patients is persistent severe cytopenia. So grade 3 or higher cytopenia persisting up to day 30 or beyond after CAR T-cell infusion. And its frequency is really the same across all products, around 30%. What is interesting, this is way higher and more persistent than we tend to see with use of FCR in CLL. So it doesn't seem to be just myelosuppression from lymphodepleting chemo, and CAR T-cells seem to play a role. It's a very clinically meaningful problem. These are patients who have persistent myelosuppression up to 2 years after CAR T-cell infusion, and patients who end up needing blood cells or platelet transfusions or developing infections requiring hospitalization for a very prolonged time. And it's not just a matter of myelosuppression, it's also a matter of lymphodepletion. These are patients who may have low CD4 and pretty much in the HIV range for longer than a year, which is why, going back to the original slides on chronic viral infections, it's really important to maintain antiviral prophylaxis and anti-PJP prophylaxis for at least 1 year after CAR T-cell infusion. And of course, these are patients who also have very severe and persistent hypogammaglobulinemia. Of course, all this translates into frequent infections that tend to be fungal and bacterial initially in the first couple of months, and more viral and PJP type of pneumonia subsequently. So use of antimicrobial prophylaxis, again, antibacterial and antifungal for the first few weeks, but antiviral and anti-PJP for at least a year after CAR T-cell infusion is really crucial. As I mentioned before, it doesn't seem like this is just due to lymphodepleting chemo-associated myelosuppression. And we looked into cytokines that were enriched in patients who developed cytopenia. And clearly, cytokines produced by macrophages, such as, for example, interferon gamma, are meaningfully increased in this patient, both in terms of area under the curve, but also in terms of peak 30 days after CAR T-cell infusion. And as expected, patients who have cytopenia have a significantly greater CAR T-cell amplification, once again demonstrating the CAR T-cells per se mediate cytopenias, though yeah, we don't fully understand the biological mechanism, and we hope to share with you more again at upcoming ASH regarding our translational work in this field. But beyond toxicity, one additional item that still represents a major challenge and where we're trying to work to our research is trying to increase efficacy. One way we're trying to do this is by adding something to CAR T. By saying something, I'm really referring to a lot of agents that can be aimed either at increasing CAR T cell activity or enhancing the microenvironment. This is just a list of some of the combination trials currently ongoing in the United States with all three products, and it's a very long list. But another way that we can try to increase efficacy is trying to target those patients who are in PR as opposed to CR 30 days after CAR T-cell infusion. We know that those who are in CR on day 30 have an 80% chance not to progress subsequently. But those who are in PR have a 70% chance to subsequently relapse. And it sounds evil that despite that, we really just watch these patients and we don't currently offer any consolidation treatment. The problem is that we don't really know who these patients are. There are some data from the Stanford group showing that maybe ctDNA may be a way to identify these patients, but of course, ctDNA is not a commonly available clinical tool. At MD Anderson, we have been able to demonstrate a more commonly available clinical tool, which is SUV maximum on PET-CT scan on day 30, may help to identify those patients who will subsequently progress with a threshold of 10. So pretty much those who have an SUV maximum less than 10 are most likely those who will subsequently convert to CR and will never progress. So these are patients where it's really important to work on developing novel clinical trials of consolidation strategies. But of course, this needs to be biologically rational. And finally, the final challenge that we need to, that we're trying to address to our active clinical and translational research is what to do with patients where CAR T cells don't work and patients are either primary refractory or subsequently relapse. As you all know, only 1/3 of these patients tend to be CD19 negative. And these are patients where we can use, we can target other antigens such as CD79B through polatuzumab or XPO1 through selinexor. But 2/3 will still be CD19 positive. And so in these patients, we can still use standard options in the United States, still targeting CD19 by using, for example, tafasitamab or Lomcat. And in both scenarios, of course, we can try to enhance the tumor microenvironment by using immunomodulatory agents such as lenalidomide or pembrolizumab, though the use of these agents in large B-cell lymphoma still remains off-label also in the United States. Definitely the right answer, no matter what in these patients, is clinical trials. Because as you can see in the next slide, when we use standard treatments, when it comes to clinical trials, there are many pathways that can be targeted. We talked about the immune microenvironment. There are very encouraging results looking into agent targeting tumor-associated macrophages, targeting the apoptosis pathway, and further targeting the B-cell receptor that, of course, is crucial for the survival of B cells, particularly when they become refractory to CAR T-cell infusion. So really, research is very active in this field and is definitely the next stage of research when it comes to trying to address challenges in CAR T-cell therapy. With this, I would like to thank all my collaborators, of course, all my colleagues within the Department of Lymphoma and Myeloma, stem cell transplant, in particular, Dr. Nilo, who has been leading efforts in CAR T-cell at MD Anderson. Our colleagues in radiation oncology, neurology, neuroradiology, they've been crucial for the management of neurotoxicity in our patients. And I would like to thank you all for your attention, of course, all our patients and patient families, and I'll be happy to take any question that you may have.
Thank you so much, Dr. Stati, to make it so simplified. We do not do CAR-T ourselves, but understood everything that you spoke. So we have our colleagues over here, and they would probably like to ask you some questions. Please go ahead.
So, Dr. Paulo, this is Dr. Ashish Bakshi.
Nice
Can
to
you
meet
hear me?
Yes, I can hear you.
Yeah. So, actually, what can explain the failure of tisagenlecleucel as compared to the other two drugs? What is the reason why it didn't succeed as compared to the other two drugs?
Yeah, that's a very good question, and still a very active field of research. Yeah, we don't fully understand why CAR T cells don't work in some patients. Some mechanisms have been identified. So we know that 1/3 of patients may eventually downregulate CD19. The products currently approved by the FDA do target CD19, and a lower expression of CD19 before CAR T cell infusion is actually associated with worse outcome. Because what may happen is that there may be a selection of a clone where CD19 has a very low expression to no expression. And then, of course, in that case, anti-CD19 CAR T cells may not work properly. One other mechanism that has also been clearly identified is T cell fitness. So the issue is that these patients are very heavily pretreated. And this is an autologous T cell product. So they are the patients themselves T cells. So when we collect them, they may already been weakened by previous chemos that they received, including stem cell transplant. And so even if they clearly recognize CD19 and the lymphoma doesn't downregulate CD19, they may just not work well, which is why there are ongoing trials combining CAR T to Pembro, Nivo, Revlimid, you name it. Finally, recently there have been some data showing that the apoptosis pathway may be a mechanism of resistance. There's been a publication from MSK showing the patients who have TP53 mutations and other mutations relevant to apoptosis pathway. They seem not to die in response to the cytotoxic activity of CAR T cells. And there's a lot of interest in trying to target CDK9 that helps to downregulate all relevant apoptotic proteins after CAR T cells. These are only 3 mechanisms that we have identified, but there are many more to come. And as a matter of fact, I think that is really important, and that's what our institutions and many are trying to do, to perform tissue biopsies in these patients. We cannot really limit to liquid biopsy because they may not be informative enough to better characterize the biology of these patients. It's a very good question. Dr. Shah?
Yes, sorry, I joined a bit late, so I'm not sure if you answered this, but are there any trials of the earlier autologous transplant in high-risk patients? There were trials which failed, like stage 4 and various high-risk category. Are there any such trials for CAR-T ongoing where, as you were saying, maybe these T cells may even work better where there is less chemotherapy exposure also?
Yes, that's also a fantastic question, and the answer is yes. So one was actually, so if you look into the randomized phase 3 trials that in the US have brought to the approval of Axicel and Lisacel in second line, patients who relapsed after transplant could go to CAR T, but also the other way. So if they relapsed after CAR T, they could go to stem cell transplant. The data from the specific cohort of patients that went from CAR T to autologous stem cell transplant have not yet been fully published, but some real world data have been presented from our CIBMTR, our transplant group in the US. And these patients seem to, have tolerate transplant. They don't seem to be any higher risk than patients who did not receive CAR T previously, but to have an outcome which is probably similar to those who did not receive CAR T previously. So overall, with a cure rate still close to 30 to 40%. At our institution, we have tried to combine autologous stem cell transplant to agents targeting chemo refractoriness. So as you know, one issue is that these patients may be chemo refractory, and you may argue that there would be no point to send them to autologous transplant after CAR T, because of course, autologous transplant is just atomic bomb chemo followed by a stem cell rescue so that you don't die. Sorry to put it down this way. So we really want to try to resensitize to chemo those cells. So what we have done, we have combined autologous stem cell transplant to olaparib, which is a PARP inhibitor. This data will be presented by Dr. Nieto, our transplanter at upcoming ASH, but results are jaw-dropping. We see response rate higher than 70–80% in patients who previously had CAR-T. So I think that yes, autologous stem cell transplant is not that yet. In a large B-cell lymphoma, it may actually be the ideal rescue as long as it combined to novel agents for those who relapse after CAR-T.
So you're saying you use olaparib, that is
Olaparib
after transplant?
in combination as part of the conditioning chemo before autologous stem cell transplant after CAR-T, but that's within a clinical trial.
Interesting.
Thank you, Chirag. Ashish, you have another question?
Yeah. So another question that I had was that you mentioned that on day 30, if somebody doesn't have a good response to the CAR-T therapy, they tend to have a poor prognosis. So like we do tandem autologous transplant, is there a possibility that patients can be re-challenged with an additional dose of CAR-T in case if they do not respond by day 30?
Yeah, this is a very important question. So this has been done in the original Zuma one. Was really the first product approved for large B-cell lymphoma, and it didn't work. So we don't currently re-challenge with axi-cel. Sometimes, but in my experience, the results are not positive. If somebody received previously a product like Kymriah, Tisa-cel, that we feel not to be as effective as axi-cel, or a product that was out of specification, so had a viability less than 80%, we do try to give Yescarta or an in-specification product, but still outcomes are not that great. I think that in those patients, what I was alluding to, it would be better the same way you do for high-risk patients who go for autologous stem cell transplant, to give some sort of consolidation strategy. So we don't know yet what's the ideal consolidation strategy. And the reason why we don't know that is that patients who have a PR or a stable disease after 30 days after CAR-T cells, we don't really do a tissue biopsy. We don't know how their tumor looks like, what markers are expressed, and we just watch them. That I really think is evil, because we know that 70% of them will eventually relapse. I'm about to open at MD Anderson this month, actually a consolidation study where we will use LonCAR-T, the anti-CD19 drug conjugate, for exactly these patients who are in PR or a stable disease 30 days after CAR-T cells. So hopefully next year we'll have some data. And SWOG, our cooperative study in the United States, is doing the same with polatuzumab. So we're trying to see whether the FDA-approved agents that we have in third line, like Pola, TAFA, or LonCAR-T, may be used as consolidation strategies, but we don't have data yet.
Thank you.
Thank you. Any other question, please?
Yes,
So can I ask one more question? Yeah, Chirag, go ahead.
Yeah. So what are the patients who are not good candidates for CAR-T?
Yeah, so this is still very debated. I would say in the past, when CAR-T was done initially, one concern was age. The same way would be for stem cell transplant. But now multiple groups and even in clinical trials, we're clearly seeing that age doesn't matter. And we do give CAR-T in patients who are 80 or older. So that's not a concern. And actually, there was at some point, multiple real-world retrospective studies demonstrating that patients that were not otherwise eligible for clinical trials based on counts, renal function, cardiac function, will still do well with standard of care products. So in my experience, I would say that the worst predictor is, as I briefly mentioned in the presentation, performance status. So patients who have a PS of 2 or worse, they don't do as well. And we know that PS can be a reflection of multiple things. Sometimes can be a reflection of the lymphoma itself. And in that case, at our institution, there is always a debate, what shall we do? But if it's instead, let's say if those patients have a very low tumor burden, and very clearly the poor performance status is not a reflection of their lymphoma, but it's a reflection of their age, their other medical conditions, we know that those patients are very likely, unfortunately, to die the first 30 days due to CRS or ICANS or infectious complications. So definitely, those are patients that we like, if possible, not to send for CAR-T. When it comes to cardiac, respiratory, and renal function, we tend to be very flexible. We are okay with an ejection fraction of 40%, doesn't need to be 55. We are okay with an eGFR of 30 ml per minute, doesn't need to be 60. We are okay with a VLC of 55, doesn't need to be 70%. There's some flexibility around that, so we're less strict than you will be with stem cell transplant. But there are multiple groups, including ours, trying to identify scores to determine who is a higher risk of CAR-T-related mortality. So then maybe we can direct those patients to bispecifics, for example. Now in Europe, some bispecifics have been approved for indolent B-cell lymphoma, and most likely they will for aggressive B-cell lymphoma in the near future. So I think that, not everybody will be cured by CAR-T. Some can be killed by CAR-T. So it's really important, as you alluded to with your question, to identify who may be better to direct to something different.
Chemorefractoriness is a contraindication, or?
No, both in the pivotal studies and real world practice, being chemorefractory is not associated with a worse outcome with CAR-T. So usually that's not an element to exclude patient from CAR-T cell therapy.
So if we are thinking of somebody for CAR-T, we don't have to achieve a good partial response, nothing like that. We can straight away think of them after a relapse, for example.
Yeah, so that's also a really important question. It would be important, if possible, to decrease as much as possible the quantity of lymphoma the patients have as they go into CAR-T, because there's been multiple studies, the main from Moffitt Cancer Center, showing that the tumor burden is most likely the most important predictor of toxicity and efficacy. So those who go into CAR-T with very large quantity of disease, they are more likely to develop CRS, ICANS, and not to benefit of CAR-T. So let's say, if you look into all comers, efficacy, cure rate with CAR-T is 40%. But if you look into high tumor burden, is like 10%. But if you look into high tumor burden, can be as high as 80%. So yes, I mean, it doesn't really matter. Technically, you don't need to be in CR or PR to go for CAR-T. But if you could decrease disease, I think it would be in the patient interest.
Thank you.
Ashish?
Yeah, one question that I had was that in some of the trials, they're trying to combine anti-CD52 antibody with the CAR-T. So what is the rationale for combining anti-CD52?
So it's that's more for allogenic products. So in the I think you're referring to the allogene product, Allo501. So that's it's not an autologous. It derives from donors, multiple donors, and it targets CD19 and has been engineered so that there's no rejection. So the issue with allogenic products, of course, remains rejection. So in that case, the lymphodepleting strategies need to be a little bit more aggressive. So they don't limit to fludarabine and cyclophosphamide, but they will give something like similar to alemtuzumab, so an anti-CD52. As you know, Dr. Neela Anderson has led the study, and we had multiple patients enroll. It's definitely an effective strategy, even for patients who relapse after CAR-T, as long as they still have CD19 expression. But in my experience, the use of alemtuzumab on top of fludarabine and cyclophosphamide typically associates with very severe infectious complication with opportunistic infections, and sometimes even development of second cancers due to very severe immunosuppression. So there's some work around that. There are other allogenic products like targeting CD20, where instead of using anti-CD52, they just give a higher lymphodepleting chemo. And so far, they're shown to be safe, hasn't really translated into more infections. So it may be better to work on the lymphodepleting chemotherapy dose as opposed to adding an anti-CD52 that doesn't yet seem to be safe for large B-cell lymphoma.
Thank you, Ashish. One question from the audience. In experimental studies, what changes occur in T cells if lymphoma cells are introduced into the blood?
Yes, that's a very good question. Yes, there have been historically several studies. One limitation is, of course, this needs to be xenograft model, so the immune system is manipulated artificially. And of course, what happens in animal models may not reflect what happens in human models. But we do actually have data from both, so preclinical in mouse and translational in humans. So we know the lymphoma cells, and it tends to happen more for indolent B-cell lymphoma, such as CLL or follicular lymphoma, to cytokine release tend to hamper what is called the immunological synapses. So the ability of T cells to be able to exert their cytotoxic activity against tumoral cells. We know that this is actually not limited to T cells, but also to macrophages. As you all know, B cells can express CD4T7. It's a do not eat me signal, which is recognized by SIRP-alpha on the macrophage side. So also macrophages tend to become more pro-tumoral, and they will not phagocytize B cells, and they will release more pro-tumoral and nurturing cytokines and chemokines. So yes, for, again, both in preclinical models and in patient-derived samples, very clearly, B-cell lymphomas try to make T cells and myeloid cells more pro-tumoral.
Thank you. I may have a very basic question for you. If there is an adult ALL who has relapsed and he has been brought into complete control, MRD negative, he is transplant fit, he has got a full match sibling donor, he should be allotransplanted or he should go for CAR-T?
Yeah, so I need to disclose that I don't treat B-ALL, but I'm familiar with this question because, of course, it's been a major debate over the last few years. So very differently from large B-cell lymphoma, where in case of CR after CAR-T, we will not consolidate with anything else. We will not do any type of transplant. Increasingly in B-ALL, if a CR MRD negative is achieved, they do actually tend to proceed whenever possible with allogeneic stem cell transplant. So I understand that this is done, but again, I don't treat myself B-ALL.
Fair enough. You give the answer. Thank you.
Thank you.
More questions? We have a couple of minutes.
So, Dr. Paulo, I have one more question. In future, do you foresee that it will be possible to create the CAR-T cells in institutes instead of in specialized facilities? What is the progress in that direction?
Yeah, sounds like you may be having some contacts at MD Anderson. Yes, that's what we're trying to do. I mean, many institutions are trying to do that because to decrease the cost. Currently, unfortunately, manufacturing can only, well, not anymore. That's not really a true statement anymore, but it's mainly done by the industry. So in the United States, Gilead for Yescarta, Novartis for Kymriah, and Celgene BMS for Breyanzi, and they're associated with a very high cost. So many institutions are developing GMP facilities where you can generate your own T cells. It's a very painful process, not just for in terms of equipment and supplies. That's easy to eventually gather, but more in terms of certification, because of course there are some regulatory aspects that need to be met. Many academic institutions already have their GMP lab up and running. So we do produce our own CAR-T cells, and many other institutions do, but they are currently considered experimental. The ideal scenario would be that any institution, no matter whether it's academic or not, could be given the means to produce their own CAR-T cells, and that would meaningfully decrease the cost. Which is, I'm not familiar with the healthcare insurance system in India, but in US is definitely more relevant than in Europe. In Europe, as you know, there's not really an insurance-based system, and so costs to insurances and patients are sometimes a barrier to access to CAR-T cells. So being able to produce those in-house may meaningfully impact that.
Thank you.
Thank you. So wonderful lecture, great question answer session. Thank you very much, Dr. Stati, for being with us for this hour. Thank you.
Thank you so much for having me, and thank you for the great questions. I love this dynamic talk. Thank you so much.
We'll bring you to Mumbai one day.
Yes.
Bye-bye.
Have a good day.
Bye. Have a wonderful day. Yeah.
Bye.
So we have a couple of minutes. So we'll have a little break and reassemble at 7:30. Good evening, friends. We begin our second lecture of the day, and we have Professor Dr. Davide Rossi from Switzerland. To introduce him, Institute of Oncology Research, University della Svizzera Italia, Bellinzona, Switzerland. He obtained his specialization in internal medicine, PhD in clinical and experimental medicine from University of Eastern Piedmont, where he served as a professor of hematology until 2015. 2015, he moved to Switzerland, where he is the head of the experimental hematology research program at the IOR, deputy head of the division of hematology, and co-chair of the clinical lymphoid tumors investigation program at the Oncology Institute of Southern Switzerland, IOSI. His research focuses on lymphomas and chronic lymphocytic leukemia, with more than 330 publications in international peer-reviewed journals. He's also the principal investigator of national and international clinical trials in the field of CLL. He contributed to the development of CLL guidelines and co-authored the 2016 WHO classification of hematological malignancies. He serves as editorial board member of Blood, the official journal of American Society of Hematology, Blood Cancer Discovery, and the Hemasphere, the official journal of EHA. He is member of the organizing committee of the International Conference on Malignant Lymphoma, ICML, and of the Congress of the European Hematology Association, that's ER. His research is funded by grants from the European Research Council, Swiss National Fund, Leukemia and Lymphoma Society, Fond Action, and Dr. Ettore Bali Foundation. He's going to lecture today on development of liquid biopsy for research and clinical practice in lymphomas. Over to you, sir.
So thank you very much, Professor Agarwal, for giving me the opportunity of discussing with you today on the liquid biopsy in lymphomas. And let me share the screen, okay. Which is a relatively new topic in the hematology field, and I think a bit less advanced than what it is in the solid tumor. My presentation is divided in three major parts. The first is in the first part I will try to landscape a bit the concept of cell-free DNA and circulating tumor DNA. In the second part, I will show you the main results so far achieved in terms of investigation of the role of cell-free DNA and circulating tumor DNA in lymphomas, while in the last part, the third part, I will show you some new and unpublished data that we are generating in here in our lab in Bellinzona, specifically related to circulating tumor DNA application in Hodgkin lymphoma. So let's start with the first part. We should divide to determine or define what is behind the terminology of cell-free DNA and circulating tumor DNA. Cell-free DNA consists of short stretches of double-strand, usually, DNA that circulate when we are dealing with a plasma as a liquid of the body in the plasma. It is free in the plasma. And it is a physiological molecule. All of us have a certain amount of cell-free DNA circulating in our own plasma, because it comes and it is derived or released from cells that physiologically undergo apoptosis during the renewal, the constant renewal of the hematopoietic and lymphoid system. In cancer patients, a proportion of the circulating tumor or the cell-free DNA is represented by stretches of DNA released by the apoptotic tumor cells. And this is the paraction of cell-free DNA that we term circulating tumor DNA. We can distinguish cell-free DNA in general, which may be of physiological or tumoral origin. All of these pieces are admixed in the plasma of cancer patients by using or utilizing a tumoral fingerprint. And a tumoral fingerprint, for example, in lymphoid malignancies, might be the tumor-specific immunoglobulin gene or T-cell receptor rearrangement, or otherwise, and more in general in cancer, tumor-specific somatic mutations. And we can, by identifying a somatic mutation in a stretch of cell-free DNA, for example, this one, we can nominate it as of a molecule derived from the tumor, while the stretches of DNA that are devoid of mutations likely derive from normal cells. Cell-free DNA has some biochemical characteristics. The typical size of those stretches is around 170 base pair. Its concentration is very low in healthy subjects, about 5 nanograms per milliliter of plasma. The concentration of cell-free DNA increases when there is a turnover of apoptotic cells, like for example in cancer, but also in inflammation. And indeed, cell-free DNA is also investigated as a biomarker, an early biomarker of inflammation. It is a molecule having a relatively short half-life, around 2 hours, and can carry different aberrations, which can be all typed on cell-free DNA in tumor patients, including mutations, but also translocations, insertion, deletions, chromosomal abnormalities, or also epigenetic changes. Where is the advantage in lymphoma patients of using the plasma as a source or potential source of tumor DNA compared to the cellular part of the blood, I mean the PBMC? Well, this advantage is specifically related to lymphomas which lack a leukemic component, like for example Hodgkin lymphoma or diffuse large B-cell lymphoma, where tumor cells do not circulate in the cellular part of the blood. And in this experiment, you see in the relative correlation between the number of lymphoma-originated DNA molecules observed in the cellular fraction of a bunch of diffuse large B-cell lymphoma patients compared to the number of lymphoma-derived DNA molecules identified in the plasma fraction. And for each patient, there is a clear 100 or 200-fold higher abundance of fragment of lymphoma derived DNA than in the cellular fraction. So the plasma is enriched, much more enriched of tumor-derived DNA in diffuse large B-cell lymphoma, but this is also the case for Hodgkin lymphoma. And therefore, these provide the proof that the plasma can be a source of tumor DNA for genotyping purposes in these lymphoma types. Which are the general applications of this technology? I mean, the qualification, so the definition of the mutations using circulating tumor DNA of a given lymphoma and its quantification. Well, the qualification of ctDNA, which means identification of the mutation, may provide before treatment the landscape of the mutational profile, and this may be relevant if we would like to identify mutations that have therapeutic implications, although today they are relatively few in aggressive lymphomas. But it might be also the case if at the time of relapse after therapy, you would like to identify eventual mutations that drive resistance to a given agent. Again, this is a model that is less developed in lymphomas compared to solid tumors. But you can also quantify the circulating tumor DNA, and I will show you later that the quantity of circulating tumor DNA before therapy is a strong proxy of the total tumor volume, which is one of the most important prognostic factors in lymphoma. But you can also measure under therapy or at the end of therapy the remaining amount of circulating tumor DNA to track in a sort of way the residual disease and to better define the response assessment to treatment. Many methods allow to investigate by quantify and genotype the ctDNA. There are PCR-based methods, as well as there are sequencing methods relying either on the research of the immunoglobulin gene or TCR rearrangement, or methods that utilize panels looking for or scanning a portion or a more or less large of the genome for mutations. And all of them have been utilized and tested in lymphomas. During this presentation, I will discuss with you mainly the CAPSIC technology, which is the one that we utilize in our lab and is also the one that is has the largest experimental use and validation in lymphomas. Why we are using CAPSIC? Because this technology allows high sensitivity and accuracy. And why I'm saying that? Well, the ctDNA, as I said before, the abundance of ctDNA in the total cell-free DNA that circulate in the plasma of a cancer patient is very small. Here on the right-hand side of the slide, you see a bar graph where each bar is the allele frequency of a given mutation identified in the genomic DNA of a lymphoma patient. The scale is this is a log scale, and so you have mutations which are homozygous, 100% of the allele frequency, 50% heterozygous, and then subclonal mutations. Many of those mutations, as you can see, are above have an allele frequency that, or a representation in the tumor that is above 1%. While on the left-hand side here, you can see a bar graph showing the allele frequency of different mutations identified in the cell-free DNA of lymphoma patients. And there is only a minority of mutation well abundant, more than 10%, which is an allele frequency that is really, so if you have a mutation more than 10% of the allele frequency, your assay, any assay is relatively robust to identify that. The gray zone are the mutations that are below this threshold, especially when you are around 1% or even less than 1%, because in this gray zone, and these are the most frequent mutations, the one very tiny in cell-free DNA. And why it's problematic? Because here you are very close to the background noise of the sequencing, so to the false variants that the PCRs and the sequencing introduce into the sequences, and you need to fine-tune your the chemistry of your technology and the bioinformatics to suppress the background noise and highlight the true variants in order to be, as I said, specific and sensitive. And CAPS-seq has this advantage, coupling chemistry and a bioinformatics that allow to suppress the background error and allowing to reach a sensitivity, so, I mean, a capability of detecting variants down to an allele frequency of 10 to the -3 with a certain degree of confidence. Another aspect that you should take into account when dealing with cell-free DNA analysis for mutation, for the assignment, for the identification of a mutation of cancer, is that in the plasma, you may find also mutations that have nothing to do with the cancer that you are investigating. If you remember, I said before that the most part of in healthy subjects, but also in tumor patients, cell-free DNA contains a lot of molecules of DNA deriving from the hematopoietic cells, which implies that it contains also mutations derived from the clonal hematopoiesis, which is a relatively frequent phenomenon, especially after a certain age. And there are some mutations, for example, p53, which, but also TET2, which are shared between, because they can occur both in lymphomas, but also in the clonal hematopoiesis. So if you identify a p53 mutation in the cell-free DNA, how can you assign this to the clonal hematopoiesis versus the cancer? Well, this can be easily done by censoring the variants of the clonal hematopoiesis. And you can do this by analyzing in pair, along with the cell-free DNA, also the leukocytes of the patient. You will find in the leukocytes of the patients the mutations of the clonal hematopoiesis, and you will subtract them from the list of the mutations that have been detected in the cell-free DNA. Which is the capability of ctDNA genotyping compared to genotyping of the tissue in a lymphoma patient, in an aggressive lymphoma patient like a DLBCL lymphoma patient, but the case is the same for Hodgkin lymphoma. And here you see an experiment where the same panel, the same gene panel, has been tested in paired samples derived from diffuse large B-cell lymphoma patients and represented by plasma or the tissue biopsy. And you can see here in red the large overlap in the Venn diagram of the discovery of mutations in both sources of tumor DNA. So most of the mutations that you find in the plasma most of the mutations that you find in the tissue biopsy are also identifiable in the plasma. In general, this proportion ranges from 80 to 99%, depending on the case series or the paper that are published in the literature. Which are the potential applications, having said that? What about the diagnostics? The liquid biopsy, let's say, will never substitute likely the tissue biopsy in the diagnostics of lymphoma, or not in a short time, because we still have to rely for the classification of lymphomas, as you know, on the morphology, immunophenotype, and sometimes integrating also some molecular features. But there are special situations where having a piece of tissue for the typing, the histopathologic typing, is challenging or impossible. And one of these rare exceptions indeed is primary central nervous system lymphoma, where sometimes the accessibility of the lesion is where lesions are hardly accessible. For example, in this primary central nervous system lymphoma patient, where the lesion is here in a periventricular zone and very tiny, or because after you have done the biopsy, you realize that the material collected is insufficient or inadequate because of pre-analytical aspects. For example, you know that steroid pretreatment can induce the vanishing of lymphoma cells in the tissue. And in those instances, a liquid biopsy may be useful. And there is a recent report by the Freiburg group that relying on a combination of imaging features and genotyping of the cell-free DNA from blood and from the cerebrospinal fluid was able to show that the liquid biopsy has a high sensitivity, specificity, and positive predictive value for the identification of central nervous system lymphoma, which means that in the future, in situations where you cannot access a brain lesion or you have inadequate material, you can complement the diagnostics by using a liquid biopsy of plasma or cerebrospinal fluid to become confident that the tumor you are dealing with is a primary central nervous system lymphoma. The technology can also identify and profile the mutation of the tumor, and this might be relevant in the future. For example, if we will rely on the now well-known genetic subtyping of diffuse large B-cell lymphoma, which utilizes as variable for the categorization of the DLBCL, the mutational landscape. And you can reconstruct the mutational landscape using cell-free DNA as a source of tumor DNA for genotyping. But you can also measure, as I said before, the tumor load. by measuring the concentration of circulating tumor DNA in the plasma of lymphoma patients. And there is, across all the literature and across all the lymphoma types investigated for this, a strong correlation between the circulating tumor DNA levels and the stage of the disease, which is a physical proxy of the tumor load, or between the concentration of ctDNA and the metabolic tumor volume, which is a more precise measure of the tumor load based on PET scan. Finally, as I said before, you can use this technology to track along a therapy whether mutations are acquired. And here you can see the proof that you can identify clonal evolution and resistance and mutations of resistance in patients with lymphomas treated with in a clinical trial with a combination of BTK inhibitor plus a checkpoint inhibitor. And in this part of the triangle graph are highlighted the mutations that are acquired during treatment. And the most frequent mutation acquired are PLC gamma 2 mutations, which are well-known genetic marker of resistance to ibrutinib. A very novel and recent development of the circulating tumor DNA technology is the use of features of the cell-free DNA or the circulating tumor DNA, which is the fragmentation pattern, to derive the gene expression of the tumor. How can we do this? Well, as I said before, cell-free DNA has, in physiological conditions, as a stereotype way of fragmentation. The length of the fragments is around 170 base pair because it is a wrap of DNA around the nucleosome in the chromatin. And so the nucleases during apoptosis cut the DNA in the proximity of the nucleosomes where the chromatin is closed, releasing fragments, as I said, of around 170 base pair. But in regions that are highly expressed, region of the chromatins associated with genes that have a high expression, the chromatin is open. So the interval between the nucleosomes where the nucleases can cut are larger. And here, in these intervals, the cell-free DNA may be cut multiple times, creating an heterogeneity of the fragment length. And you can use or discriminate region of stereotype fragmentation, meaning closed chromatin, versus region of heterogeneous fragmentation, meaning open chromatin, to identify genes that are not expressed versus genes that are highly expressed. And of course, this may correlate with correlation with the gene expression has been clearly documented by multiple in multiple cancer type and multiple papers. And for example, this application, this technology, which is termed EPIC-seq, has been used in diffuse large B-cell lymphoma to prove that you can identify by analyzing the fragment profile by EPIC-seq of the circulating cell-free DNA of diffuse large B-cell lymphoma. You can derive the cell of origin, which is instead a phenotypic feature of the diffuse large B-cell lymphoma that is typically profiled by gene expression of the tissue. And there is a strong correlation between the classification of DLBCL according to the cell of origin by EPIC-seq, so based on the fragmentation profile of the cell-free DNA, and by the gene expression profile of the tissue biopsy. Now I will tackle in the last 15 minutes of the presentation some new data that we are generating in the setting of a classic Hodgkin lymphoma. As you know, the peculiarity of a classic Hodgkin lymphoma, which has limited the biological understanding of this disease, and for example, until the 90s, late 90s, it was unknown which was the cell of origin of Hodgkin stem cells, because the number of tumor cells are very rare. I mean, the Hodgkin stem cells are very rare in the biopsy. The rare cells are surrounded by a normal inflammatory milieu. And therefore, if you would like to study Hodgkin stem cells and their biology, you have to separate them, isolate them from the inflammatory background. For example, by flow sorting, there are some technologies, complex but efficient, or by laser microdissection. And coming back to the complexity that has the investigation of the biology of Hodgkin stem cells is the notion that in the literature, while for all cancer types we have thousands of genomes, exomes available, for Hodgkin lymphoma we have only 66 exomes published so far, which provide a certain landscape of the mutational profile, but this is still limited. We need more granularity. Let's go directly here. We reasoned that we could use circulating tumor DNA to overcome this technical hurdles, namely the need for isolating in the biopsy Hodgkin stem cells, for defining the biological features of Hodgkin lymphoma, including the mutational profile, but as I will show you later, studying the fragmentation profile, also subgrouping based on phenotypic features of the tumor cells. And we utilize CAP-seq. As I said before, this is a technology that is very accurate in quantifying and profiling the mutation of ctDNA. We set up the technology by showing that the number of mutations that are biopsy proven, so the number of mutations that you can pick up in cell-free DNA that are validated in isolated Hodgkin stem cells is very large, as you can see by the red portion of the Venn diagram. Nearly 90% of the Hodgkin stem specific mutation can be identified in the plasma by genotyping cell-free DNA. Starting from this notion, we designed a prospective observational study, which included newly presented adults with classic Hodgkin lymphoma who were treated as per standard of care, but there was a clinical follow-up, but most importantly, sampling of liquid biopsies before treatment, at the time of interim PET assessment, at the time of end of treatment assessment, and along with the ctDNA quantification and qualification based on our technology, the CAP-seq, we also centrally review the radiomic features and the response based of the defined by the PET scans. We recruited 215 patients in this study. Here you can see the clinical features, which are the typical ones of an unselected cohort of Hodgkin lymphoma patients, a median age of 39 years, most of the patients having B symptoms, extranodular involvement, a proportion being bulky. Most cases were treated with ABVD, usually without a PET-guided approach, so not changing treatment according to interim PET, and unplanned radiotherapy, let's say consolidation was used in a limited portion of patients. In this bar graph, you see the number of mutations identified in the circulating tumor DNA by the CAP-seq. The range is wide. The median number is 19 mutations. We have typical mutations that are known to affect Hodgkin lymphoma based on the 66 exome sequences that are available in the literature, such as SOX1, TNF-IP3, STAT6, B2M. These are usually always in the top of the list of genetic lesions of Hodgkin. But what we observed, interestingly, and which is a novel finding, already a novel finding of this study, is that Hodgkin lymphoma, as diffuse large B-cell lymphoma, or even more, is densely affected by mutations induced by the AID, so the somatic hypermutation process. The somatic hypermutation process, which physiologically introduces mutations in the immunoglobulin genes to mature the affinity for the antigens, in diffuse large B-cell lymphoma is known, this mechanism, to misfire and affect some oncogenes like BCL6, ROH, TTF, and others. Well, this mechanism of genetic instability and mutagenesis is very active, and this was not unknown also in Hodgkin lymphoma. The first question that we asked is whether the pretreatment ctDNA is a prognostic biomarker in classic Hodgkin lymphoma. Pretreatment biomarkers are limited in this disease. The International Prognostic Score, which has been developed for the stratification of advanced stage Hodgkin lymphoma patient, has a limited discrimination capacity. As you can see here, its application to patients treated in the RATAL trial, so in a relatively modern era with ABVD, divide the population, but there are many patients that are scored at high risk that, despite this, are cured by ABVD. Another biomarker that is proposed in the literature is the metabolic tumor volume, which applies to both limited and advanced stage cases with different cutoff, but also these, so patients with a high total metabolic tumor volume, which would be regarded at high risk, are cured in a large proportion of patients. So there is a unmet need of having more discriminating biomarkers. So the first question that we asked is whether mutations, gene mutation, associate with outcome in this cohort. And in this forest plot, as it is documented and shown in many lymphoma types, for example, p53 mutation are strongly prognostic in CLL, in mantle cell lymphoma, but also in diffuse large B-cell lymphoma. Well, in Hodgkin lymphoma, and this is at variance with many other lymphomas, no pretreatment mutation among the most frequent in this cohort of more than 200 patients are prognostic. This forest plot shows the hazard ratio and the confidence interval of the univariate association between mutation and progression-free survival. And one of the mutation is statistically associated with PFS. So we reason in another way. What is critically relevant for the stratification of Hodgkin lymphoma patients? Well, are aspects that measure the volume of the disease, so the stage and the presence of or not of bulky disease, the dissemination of the disease, for example, the number of nodal areas involved, and the inflammation, the symptoms of elevated ESR. And in these are the biomarkers used by the German Hodgkin study group way of dividing patients in early, intermediate, and advanced patients. Well, as I said before, cell-free DNA strongly correlates with the volume of the tumor. This is known in many cancer types. So the higher is ctDNA, the largest is the volume of the tumor. But it's also a strong biomarker of inflammation. And indeed, it is studied now in autoimmune disease, in solid organ transplantation to early capture the flare or resurgence of the inflammation. And so we reason that in one biomarker, ctDNA level, we can capture in Hodgkin lymphoma both the features that are highly prognostic: tumor volume, dissemination, and inflammation. And indeed, we can show that the levels of ctDNA correlate with the metabolic tumor volume measured on the PET scan. We can show that the level of ctDNA strongly correlate with B symptoms, a feature of inflammation, and the extension of the disease defined by the staging. And by looking for a threshold of ctDNA load in a training cohort, we identify a cutoff, which is 650 haploid genomic equivalents per ml of plasma, that is prognostic, independent as a prognosticator of progression-free survival from the stage or the total metabolic tumor volume, and validated as prognostic in a validation cohort, and nicely allows to sort out patients who are going to fail 40% progression-free survival among intermediate cases, among intermediate stage patients, and among advanced stage patients. So it adds prognostic information to the staging system. Then we ask whether during treatment, molecular response defined by the clearance of circulating tumor DNA from plasma is another, in this case, dynamic prognostic biomarker to redefine the risk of the patient as it is PET scan. We are using PET scan to reassess the risk of the patient and eventually de-intensify or intensify the treatment. However, as you can see in this cohort, which was treated with BCOP, and the stratification of the outcome is based on the positive or negative results of the PET done after 2 courses, up to 72% of patients, despite having a PET scan, are cured by chemotherapy. So again, we need a biomarker that could improve the identification of those cases at the interim time point that will eventually fail therapy. The problem of interim PET scan in Hodgkin lymphoma is that we don't know which is the number of false positive scans. I mean, those scans that have uptake of FDG, not because there is residual tumor, but because of the inflammation created by the chemotherapy and by the death of the tumor cells in the tumor site. We know that in non-Hodgkin lymphoma, after biopsying the lesion that residuate after 2 courses of chemotherapy, 83% are false positive. So in the biopsy, there is no tumor. Why we don't know this number for Hodgkin lymphoma, although we are using interim PET scan to guide treatment. In a pivotal study, in a very selected case series, we were able to document that in those patients which are here highlighted in red, that were cured by ABVD, they had a continuous complete remission after 3 years after the end of therapy, but had an interim positive PET with a Deauville score of 4 or 5. Well, those patients had no evidence of ctDNA, as you can see here in the waterfall plot that measure the change of the ctDNA levels from pre-treatment to interim time point. There are no ctDNA at the interim time point, which means that which provide the proof of principle that measuring the ctDNA at the interim time point can complement the PET scan in identifying and allows to identify the false positive results. And we tested this in our prospective study. First, we proved that interim PET per se can divide the population in low-risk cases, the blue, and in high-risk cases, the red, having positive PET. But we were able also to show that if you integrate the PET scan, the interim PET scan result with the presence or absence of circulating tumor DNA at the interim time point, you can sort out this poor risk group of patients who are all gonna fail ABVD, which are the double positive patients having interim PET-CT positive, Deauville score of 4 or 5, and persistence of ctDNA molecule in plasma. And by combining these two tools, PET and molecular response, compared to the sole PET-CT at the interim time point, the specificity for the cure of the patient increases from 87 to almost 100%, and the positive predictive value from 56% to 87%. Finally, we tested whether pretreatment ctDNA can capture the biological heterogeneity of classic Hodgkin lymphoma. And here I come back to the concept of the fragmentation, because as I said before, the fragmentation can identify whether genes that you are testing in cell-free DNA have close chromatin, so no expression, or open chromatin, so high expression. And by measuring the length of the fragments in cell-free DNA and clustering the patients, accordingly, we were able to identify two groups of patients, one having highly fragmented cell-free DNA, which means more open chromatin, and one having less fragmented cell-free DNA, which means less open chromatin. And these two groups have also a different, the difference in general, the fragmentation profile is also gene related. And I will not go into the detail, but we can distinguish the two groups very nicely, showing that the fragmentation of specific genes which are relevant for the germinal center B cells are more or less fragmented in the two groups of Hodgkin lymphoma. And these two groups are clinically different. The highly fragmented, so more open chromatin, have more advanced stage disease, more B symptoms, more elevated ESR, higher total metabolic tumor volume, and shorter outcome, with a discrimination capacity of the outcome of 62% higher than the German Hodgkin study group staging discrimination capacity. But what is interesting is that the driver of this difference seems to be the load of mutations. So the highly fragmented cell-free DNA cases are more mutations, and most importantly, more mutation driven by the aberrant somatic hypermutation. And such more mutations create more neoantigens, and more neoantigens correlate in those tumors with a different microenvironment. The highly fragmented cases having more neoantigens are enriched in the tissue, and this has been profiled by single cell RNA-seq on a bunch of disgregated lymph nodes from Hodgkin lymphoma patients defined as highly fragmented or low fragmented. The highly fragmented, having more neoantigens, have an immune suppressive microenvironment, more Tregs, while the less fragmented classic Hodgkin lymphoma patients have an enrichment in the microenvironment of tumor suppressive cells like CD4 T follicular helper cells with cytotoxic capacity and CD8 effector memory cells. So our hypothesis is that for this part, the underpinning biological mechanism of this subgrouping of Hodgkin lymphoma is that the highly fragmented, that with some mononucleosomal, has more aberrant somatic hypermutation because of more open chromatin, and therefore it presents more neoantigens. And to escape, it requires an immunosuppressive microenvironment, while the low fragmented cases have less mutations, less open chromatin, less neoantigens, and a more aggressive reaction by tumor suppressive T cells. And these two different features drives the outcome, which is lower for the highly fragmented and better for the less fragmented. So to summarize for this final part, we can show that pretreatment ctDNA is a novel prognostic biomarker of Hodgkin lymphoma. You can combine interim PET-CT and molecular response to improve the specificity of outcome prediction. You can profile the fragmentation of cell-free DNA and divide in molecular subgroups of Hodgkin lymphoma, which have different biological features, immune-oncology concepts, and also different outcome. Final remark, we already entered ctDNA into the treatment, or we are testing whether it's useful ctDNA in guiding the treatment of patients in this clinical trial, which is recruiting here in Switzerland. It is devoted to diffuse large B-cell lymphoma patients, and we are profiling at the baseline on the ctDNA the presence of mutations of MYD88 and CD79B, so of the super signalosome of the B-cell receptor that are known to sensitize cells to BTK inhibitors. And those patients having in the cell-free DNA, those mutations are treated with acalabrutinib, a BTK inhibitor, plus R-CHOP, while the negative patients are in the negative patients for mutations. The treatment is then guided by the combined PET and ctDNA response after 2 courses. For example, by de-escalating the treatment to only 4 courses of R-CHOP in those patients having a negative PET scan and a complete molecular remission. And with that, I have concluded, and I thank you very much for your attention. And I would like to thank all the people who has been involved in this study, as well as the funding agencies. So thank you very much.
Thank you, Dr. Rossi. That was a wonderful talk. Enjoyed it. I heard you in Mumbai, and now this was a longer talk, and we got so much insight into the subject. Some of my colleagues are here. They may be interested in asking you some questions. We have some time. Dr. Bakshi, would you like to ask? Yeah.
Yes, sir. Dr. Rossi, I have one question. You mentioned about the role of ctDNA in the diagnosis of primary CNS lymphoma. So 2 questions pertaining to that. Should this be measured is the plasma ctDNA reliable for the diagnosis of primary CNS lymphoma, or it should be done on CSF?
Well, cerebrospinal cell-free DNA isolated from several spinal fluid allows to is more accurate as a reporter of mutations than plasma. So it is the best source.
Okay.
And it has been shown by multiple studies, including the large cohort that I mentioned.
Okay. So a related question was that in case if somebody has a like a difficult to biopsy lesion, and in that patient, if you have a lesion on the MRI showing a suspicious primary CNS lymphoma, and if you document MID88 on the CSF, then can you go ahead with the treatment for a primary CNS lymphoma in case if you are unable to get a tissue diagnosis? Can we have that confidence in the detection of MID88 in the CSF?
You are fully right. And this is exactly the most practical way, because the data that I've shown utilize CAP-seq, which is complex technology, a large panel, but as you underscored, MID88 mutation account for from 50 to 70% of primary central nervous synapse lymphoma, and in particular one single mutation, which is the LC265, and you can tackle this mutation by PCR, which is simpler than CAP-seq. And indeed, this is a way that I know is entering the practice of different centers, which I mean, if you, as you mentioned before, you have a case where the biopsy failed or the biopsy is impossible, then the plan B is indeed combining the confidence of the imaging, the neuroradiologist about the final diagnosis, with coupling this with a positive biomarker for lymphoma, namely the detection of the mutation by PCR in the CSF.
Okay.
And this applies also to vitreal lymphoma, which are also difficult to diagnose. So there are many centers now that are coupling the suspect based on the morphology of the cytology with the detection of the MID88 mutation in the vitreous.
Thank you, Dr. Ashish. Any other question for sir?
If others don't have a question, I still have some questions actually.
Maybe one.
Can I ask?
One more.
Okay, sir, you mentioned about the fragmentome in Hodgkin's lymphoma. Can fragmentome predict the response to immunotherapy? Because as you said that there is a higher neoantigen load in the one which are some nucleosomal. So can it predict response to immunotherapy?
Yeah, we are testing this hypothesis, which is very interesting, and you are right. We collected a relatively small cohort of 45 cases treated in relapse setting, of course, with the checkpoint inhibitors, Nivo or Pembro. And the sample size does not allow the big power, but there is a clear separation of the curves, with the highly fragmented one having more neoantigens and immune suppressive microenvironment doing worse, although there is only a trend so far, given the sample size, for a statistical trend and not yet a fully significant p-value. But I think that this would be the next step to enlarge the cohort and fully document this.
Thank you. Thank you, Dr. Rossi, for that wonderful
Thank you very
talk.
much.
It was a beautiful and a very, very educative talk. We enjoyed listening to you. And maybe soon we will call you to India to...
Yeah, thank you very much again for having invited me and for giving me the opportunity to meet virtually all of you and your colleagues and share with you our data on this topic. Thank you very much, and looking forward to see you eventually in Lugano next year. We will have the Lugano meeting, and let me advertise as final remark, June 2023, the appointment for the Lugano, the lymphoma aficionados in Lugano.
We will be there. Thank you, sir.
Thank you.
Bye-bye.
Bye.
So we come to the third talk of the day, and it's my pleasure to introduce our next guest speaker, Dr. John Kuruvilla. He has already logged in, and I must tell you that he was our guest a couple of years ago, and we enjoyed listening to him. He's Professor of Medicine, University of Toronto, hematologist, Division of Medical Oncology and Hematology at the prestigious Princess Margaret Cancer Center at Toronto. He's a member of the Lymphoma, Autologous Transplant and Immune Effector Cell Therapy Programs and co-director of the Beyond Chemotherapy Program. His research interest is the development of novel therapeutics in lymphoid malignancies and incorporating translational research into clinical trials. He is the lymphoma co-chair for the Canadian Cancer Trials Group, as well as the chair of the Scientific Advisory Board of Lymphoma Canada. Today, he's going to lecture us on salvage therapy in Hodgkin lymphoma. Over to you, sir.
Well, thank you very much again for the opportunity to be with you today and presenting on this topic. What I'm going to do through this is highlight some of the issues about how we're approaching salvage therapy in this disease and setting, and also just give a little bit of historical context as well. Okay, so here are my disclosures. And so our outline for today will be looking at some of the pivotal data in terms of how we approach the use of novel therapies. We'll look at some of the randomized trials that influence how we treat patients with classical Hodgkin's lymphoma. I'll touch a little bit at the end on two other topics, potentially the evolving role of allogeneic stem cell transplant and highlight some of the challenges for managing elderly patients with relapsed refractory classical Hodgkin's lymphoma as well. So this is a slide I borrowed from Joe Connors that really highlights our growth in knowledge as we've talked about the evolution of Hodgkin's disease now to Hodgkin lymphoma, but also importantly, really highlighting some of the key changes with therapeutics over the past 100 years or more. Ultimately, where we get into the most recent decades, where certainly our innovations are being driven by the use of functional imaging with FDG PET scanning, as well as immunotherapy using the novel therapeutics brentuximab vedotin and checkpoint inhibitors. So I don't think this curve will be unfamiliar to many in the audience, but this is the one of the two randomized studies looking at salvage therapy and randomizing patients that have responded to salvage therapy to autologous stem cell transplant versus observation. And this is from the German Hodgkin study group, really looking at the role of stem cell transplant and showing the advantage here, which was the primary endpoint of freedom from treatment failure, but did not show an overall survival advantage. And this in part could be because of the small sample size of the trial. As you can see, under 120 patients ultimately randomized, though this longer-term disease control benefit was proven. And this ultimately is the cornerstone upon which we've built second-line therapy in transplant-eligible patients, though it is a small trial. Again, a brief reminder here. So this is from a review I published in Blood, over 10 years ago, really looking at the conventional chemotherapy approaches that were employed at the time, showing that based on phase 2 experiences or institutional data, that these regimens looked fairly similar when looking at overall response rate, though you may get a sense that the complete remission rate might be a bit different with certain regimens. Importantly, these were done using CT-based response assessment, and in many places around the world, these remain the gold standard because there has been a challenge with the lack of randomized data to really look at more recent regimens as well. Lastly, from a historical perspective, these are outcomes that were published looking at patients, over 750 of them, that had developed relapse post-autologous stem cell transplant. Again, a group of younger patients where you look at the overall survival here as being very poor. And whether this was stratified to look at later relapses beyond 12 months post-transplant or early relapses, you can see ultimately the outcome is very poor particularly in the setting of what is felt to be typically a very curable lymphoma. And so a lot of room to improve. And when you look at historically a number of the drugs that had been evaluated in this setting, HDAC inhibitors, mTOR inhibitors, immunomodulatory drugs, proteasome inhibitors, all of them had very modest single agent activity. And so this is the context that people really had where we started to look at what we could do to move things forward. The take-home messages, phase 3 trials had not been common historically, were very small. The outcomes in these patient populations were not particularly good, though you might argue they were at least better than what we saw in relapsed refractory diffuse large B-cell lymphoma. A subset of patients are potentially curative, but again, the numbers and how they may do very dependent on fitness for transplant and age, as well as the importance of response to traditional chemotherapy. So really highlighting the importance of the need for targeted therapy. And so the first really game-changing drug, again, was the anti-CD30 antibody drug conjugate, brentuximab vedotin. And so through a mechanism using MMAE as the payload, you can see internalization, release of the chemotherapy leading to microtubule disruption, and subsequent cell cycle arrest. Again, the immune component to this may be a mechanism called immunogenic cell death, which certainly has been studied preclinically, though we may not understand the importance of it truly from a clinical perspective. So these are the data published by Anas Yunus now 10 years ago in over 100 patients post-autologous stem cell transplant with progressive disease, which showed a very encouraging overall response rate by independent review, 75%. A third of patients developed a complete remission, as you can see. And unfortunately, that did not translate into a huge improvement in progression-free survival. As you can see, the median there is under 6 months. What I will say, about 10% of the patients on this study continued in remission 5 years after treatment, and maybe that in part relates to the subset that benefit from this, and as to why that may be, maybe that immunogenic cell death mechanism has something in part to do with that. This then led to the confirmatory phase 3 study for brentuximab vedotin, which is called the ATHERA trial. And this demonstrates a progression-free survival advantage for patients post-stem cell transplant that had higher risk of treatment failure at the time they were enrolled into the study. And this was compared with our standard post-transplant, which would be not to proceed with any type of maintenance. And with longer follow-up of this trial, so this was again originally published in The Lancet in 2015 by Craig Moskowitz, that PFS benefit was maintained at 5 years with longer term follow-up, though an overall survival advantage was never demonstrated. Now, I've highlighted the number needed to treat here of 8 in terms of providing patient benefit. So certainly clinically meaningful. The toxicity are things we're familiar with the drug, mainly the myelosuppression, so neutropenia in about 30% of patients, that was grade 3 or 4, and peripheral neuropathy in about 15%. And the overall survival does need to be colored because a good proportion of patients, almost 85% of them, went on to receive BV in the control arm in not really planned crossover, but because it was the standard of care in that patient population if they developed progression. And so the important thing here, that long-term progression-free survival is cure, whether or not there's survival advantage. And I would argue that's a very important thing to think about when discussing this result with patients in the clinic. So the standard of care then was defined based on randomized trials for autologous stem cell transplant and for post-transplant BV maintenance. But the choice of salvage therapy continues to be driven by local experience in phase 2 data sets. And so that's one of our big challenges here. And I'll now show you some of the data that looks at incorporating novel therapy into the second line setting in patients with relapsed refractory classical Hodgkin's lymphoma, and really focusing on firstly brentuximab vedotin because it was the initial drug developed. And then I'll tell you a bit more of the story about checkpoint inhibitors. So here's one of the approaches, and this was pioneered in the US by groups on the East and the West Coast. So Alison Moskowitz published an experience of brentuximab vedotin as monotherapy, and if patients were to achieve a CR, they could then go straight on to a transplant. And you can see there that response rate for a CR was about 27%. If you go on to get augmented ICE chemotherapy as the program, ultimately 3/4 of the patients will achieve CR. You see very favorable PFS at 2 years and very manageable toxicity from brentuximab vedotin. The difficulty here is that even though this experience was largely replicated in the study that came from City of Hope published by Alex Herrera, the challenge is that you're giving a sequential therapy, a subset benefits to a CR and other subset benefits from chemotherapy. We generally like to combine therapies together. And if you're trying to spare toxicity by using BV monotherapy in the patients that achieved a CR, you go on to give them high-dose chemotherapy, which comes with all the toxicities that we're all familiar with. Importantly, though, they were able to show that with this platform, no concerns around the transplant in terms of engraftment or peripheral blood stem cell mobilization. And again, the toxicity was very manageable. The alternative approach is to look at combining salvage therapy conventional regimens with brentuximab. And this was done initially in phase 1 and phase 2 studies. And I've highlighted 5 of those trials here, looking at BV in combination with bendamustine, platinum-containing regimens like ESHAP, DHAP, or ICE, and lastly, IGEV. And what you can see in these phase 2 experiences here are very encouraging overall response rates, all above 90%. And you can see CR rates anywhere from about 70 to 80%. And this again translates to very favorable progression-free survival at 2 years. The toxicities here, the important thing to recognize, again, with BV bendamustine, infusion-related reactions was something that was an issue. But secondly, febrile neutropenia, so the myelosuppression when giving BV in combination with chemotherapy, tends to be an issue. And you can see potentially with ICE that also translated to an important infectious risk. So important to think about GCSF prophylaxis when you see that FN rate would be very reasonable. And similar to the other studies, no issues around transplants or mobilization or engraftment. And proof of concept, I think, that you do see evolution in the response rates and very impressive CRs. Now to switch gears, the other agents that came up were checkpoint inhibitors. And when you look at the biology here, there's still a bit of hand waving to really explain mechanism here. But in a tumor with a lot of microenvironment, when you look at the HRS cells themselves, you do see genetic amplification at 9p24, leading to upregulation of PD-1 and JAK signaling. And the hypothesis here is genetically driven dependence on PD-1 in classical Hodgkin's lymphoma. So here are just very quickly the results of the phase 2 studies that led to the approval of these drugs. Nivolumab on the top, pembrolizumab on the bottom, 3 different cohorts looking at patient populations typically post-transplant based on if they had been exposed to BV or where they had been in their time course. The pembrolizumab data did include a cohort that had not had a stem cell transplant. And what I want you to take home from this slide is really the results look quite similar in that the response rates are right around 70%, maybe what looks like a slightly higher CR rate from the Pembro data, but the PFS data looks pretty similar at about 14 months, although the median follow-up at the time of these reports was still relatively immature when you're looking at between 18 to 28 months. So with the activity looking good, the toxicity looked very similar as well, very manageable. You have to look at other characteristics that may define how you pick which drug that you use, whether that's the frequency of schedule and the fact that one may be an indefinite program with a nivolumab and pembrolizumab had a fixed duration of 2 years, but very encouraging data leading to approvals in many countries. But importantly, a registrational phase 3 study needed to be done. And so just in one slide to highlight this trial, Keynote 204, which was the comparison between pembrolizumab and brentuximab vedotin in a patient population that was ineligible for transplant or had relapsed after a transplant. And the primary endpoint is the Kaplan-Meier curve on the right. So looking at progression-free survival in all patients, statistically significant, clinically meaningful difference of 5 months, looking at 13 versus 8 months for the control arm, and really a positive clinical trial. The response rate endpoints did not reach statistical significance, though there was a 10% difference and a p-value which looks statistically significant, but given multiple testing, it did not reach the predefined threshold for significance. And the toxicity, both drugs have a different toxicity profile, but exactly what you would have expected based on all of the experience out there from phase 2 data. So more immune-mediated toxicities with pembrolizumab, and again, neuropathy and myelosuppression being more common with brentuximab. So the context here is when we see the activity of PD-1, how might that be incorporated into salvage patients and into patients going on to transplant? And so this is a complex study that came out of the US, and the first author was Reed Merriman, published last year in Blood Advances. But what I want you to take home is in the middle box. And this looks at what happens when you give a PD-1 based salvage therapy to patients that may not have responded to second-line therapy with traditional regimens or potentially brentuximab vedotin. And what you can see there is that between CRs and PRs, you have about an 80% response rate. So, just say in the ballpark of what we see from the clinical trials looking at PD-1, and you're able to take patients to transplant. In a subset of those patients, if they didn't respond, they go on to get intervening salvage therapy. And then when you look at the curves at the right, so firstly, if you look at PET positive versus PET negative, you see very good outcomes in patients that go on to have a stem cell transplant, but they look more favorable in the patients that are PET negative. And if you look at, if you had to give additional therapy after the checkpoint inhibitor, well, certainly in the patients that achieved a good response to the checkpoint inhibitor, they appear to have, again, a favorable progression-free survival. But even the patients that required intervening therapy, you see the potential for durable remissions, though again, the follow-up still remains relatively short. So a retrospective study looking at incorporating PD-1 blockade into patients that then go on to have a stem cell transplant. What I'm going to show you here also is looking at Keynote 204 and highlighting some of the data from ASH, where you look at what happens in patients that only get one prior line of therapy. And so again, this was the subset of patients that were not transplant eligible versus those that had 2 or more prior lines of therapy, so maybe a little more likely to be post-transplant. But what I want to get at here is, how do patients do with a checkpoint inhibitor or BV right after one line of therapy? And what you'll see here, it's a smaller data set, about 50 patients or so. But the beauty here is that it is a randomized comparison, though again, some of the factors in terms of if you're looking at the proportion of older patients or the proportion that are primary refractory are numerically different. And again, this is a subset analysis, so we didn't really do any formal statistical testing. The take home is that even in that patient population that have only had one line of therapy and are more likely to be not really good transplant candidates, you do see that those same differences stand out, and that Pembro looks like it has a better progression-free survival compared to BV. So again, these were data that were presented at the ASH meeting in 2020. Hopefully will be in press sometime in the near future. The overall response rate, which is another thing to look at, again, holds up for Pembro in comparison to BV. And so if you're thinking about using a checkpoint inhibitor as an approach before transplant, again, another data set, how may you pick BV versus a checkpoint inhibitor? At least here, it's small numbers, but a randomized comparison also showing the response rate, at least numerically, looks to be different, maybe 14% better, favoring a checkpoint inhibitor. Now you look at the combination approaches. So I'm going to just summarize a couple of different series here that have looked at incorporating nivolumab or pembrolizumab, either with brentuximab and ipilimumab, or chemotherapy such as ICE, gemcitabine, Doxil. And what you see here, again, smaller studies still, under 100 patients, all of them, but again, very favorable overall response rates, very encouraging complete remission rates, and again, what looked to be very good progression-free survival, again, in these phase 2 cohorts. So showing yet again the feasibility of incorporating novel agents into this setting and showing the potential for good outcome. And important to think about, you will have seen a presentation looking at the primary therapy of Hodgkin's lymphoma. We're seeing the incorporation increasingly of novel therapy in the frontline setting, where it is funded based on the Echelon 1 data. and again, a clinical trial looking at checkpoint inhibitors frontline, again, 2 of them now being run internationally to test Nivo or Pembro being incorporated into frontline therapy. So it becomes important looking at regimens also that may not incorporate brentuximab. When you look at the toxicity, I just want to highlight here that checkpoint inhibitor combinations may come with some unique immune-related adverse events. And so when you look at the smattering of toxicities here, the numbers are small, but you do see Guillain-Barré syndrome, pneumonitis, colitis, transaminitis, so a few cases with liver abnormalities. And you do see a couple of events to encephalitis. You see 1 death there from grade 5 sepsis. So it's something, though these cases generally go fairly smoothly, the potential here for rare toxicities is something clinicians will need to watch if people are able to access these types of regimens. So the challenge for us, again, is when you look at this second line, unlike the trials that I've shown you earlier in Keynote, which is the only other trial that's been done in the relapse refractory setting that's randomized, the phase 2 studies look good, but in many countries, and certainly in the country where I practice in Canada, we need randomized trials to be able to show benefit over established standards, particularly with expensive drugs, in order to move them forward. The other lesson that came from Keynote 204 is what proportion of patients that were ineligible for transplant were able to go forward. So you can see in a 300 patient study, firstly, those that went on to transplant without experiencing progression, you can see about 10% of the patients went on to have a stem cell transplant. And you can see almost 90 patients or so, or over 90 patients, were able to go on to have either an auto or an allograft at some point. So that's hopefully, again, something we'll be able to dive into in the data set and be able to show you a little bit more about what happens with them over time. Now, I'm also going to highlight here some retrospective data that's been presented from the United States in a group led from the Mayo Clinic, looking at novel versus conventional salvage therapy. So 12 US centers, over 850 patients. So again, a retrospective series looking at choice in terms of regimen. And again, this will be skewed over time as well, with the novel therapy patients being treated more recently compared to conventional therapy older. And what I want you to look at from a response rate standpoint, again, things look encouraging with combination approaches. BV-Benda looks like it may be associated with the highest overall response rate at 92% and a favorable CR rate. When you look at the 2-year PFS estimates for all of them and the 2-year overall survival, so again, the overall survivals look excellent. But if you look at the PFS curves on the right there, what you see is that BV-Nivo and the checkpoint inhibitor arms appear to look the most favorable in terms of longer-term progression-free survival. So again, very encouraging data suggesting that maybe the checkpoint inhibitor might be the ideal drug to try to add into this second-line setting. Now looking at yet another retrospective data set in the absence of prospective data. So what can we do in 2022? Well, depending on the country you live in and the access you have, you're going to be potentially limited or not. And again, a lot of this data from the US is driven by their ability to either do studies or access some of these therapies in a non-label way to give this treatment. When you look at traditional chemotherapy, it's still effective. If you look at the data from the Italians with a regimen called BJEV incorporating bendamustine, that's a paper that has modern FDG PET response criteria built in as well. The outcomes look very good, but we still need, again, clear signals from prospective, ideally randomized studies. And the other thing, I think, from a clinical question perspective that remains interesting, the value of PET CR has been shown in multiple studies now, but the question of what to do in PR is an important one. Again, our group, like many around the world, have viewed PR as responsive disease, much like we do in DLBCL. We'd go ahead and consolidate those patients with a transplant. But there are data that show if you're able to employ a different salvage regimen, get a patient into CR, those patients may do as well as a patient who achieved a CR with only one prior regimen. And so this remains a difference stylistically in terms of how groups may practice. But the take-home message here is that however way you can do it, getting into a CR is good. It looks like incorporating novel therapy may be a better way to do that. Many of us can't access those drugs in the second line setting. We may have some access in the third line setting. And these are the data. So this has been a quick tour, but I've really highlighted the key data that I think is influencing decision-making to date. What can we do? So our cooperative group is trying to move forward with a prospective randomized study. So we were able to do a randomized phase 2 trial in the second line setting, transplant eligible patients, where we'll compare our national standard for salvage therapy, GDP, so it's gemcitabine, dexamethasone, cisplatin, in comparison with a novel combination of pembrolizumab in combination with brentuximab vedotin. And so hopefully that trial is about to open in the next couple of weeks. It's been centrally activated, and we'll see if we can share some data at that with what I hope will be a very important study for us to really establish the role of salvage therapy. In terms of future directions, so as I've already highlighted, randomized controlled trials are needed. Defining CR as an endpoint becomes important. How do we handle patients as we see the evolution of frontline treatment and the incorporation of novel agents there, based again on the Echelon 1 trial showing benefit, including now overall survival for BV in the frontline setting, but also as checkpoint inhibitors get used earlier, how are we going to look at all of this? And I'm going to leave you with a slightly provocative question there. Could you even imagine if some of the results look so good that we may be contemplating potentially walking away from transplants if that's possible? It's also not getting into the cost of these novel drugs, and that has to be recognized. And, even in an environment like ours in Canada, we struggle with this. And so it's important to build in those types of analyses to understand what value you may be bringing to patients and how much it costs to give these types of treatments. So I'm going to highlight, lastly, a couple of things. Firstly, looking at the role of allogeneic transplant. And again, the reminder from the prospective study led by the EBMT, chemosensitive patients going to allo tend to do far better than those that are resistant. And so I think the goal here is to really avoid taking forward patients that have not achieved a response before they have an allograft. Just to highlight again from the EBMT here, what's been happening with modern data, and what you can see, encouragingly, the non-relapse mortality has improved from the old days, but still remains an important consideration. It's somewhere around 15 to 20%. When you look at the 2-year PFS, you can see about 40% of patients, when you look at a big data set, so this was several hundred patients here, tend to benefit. And you see trade-offs based on the donor source for cells in terms of what happens. Siblings versus matched unrelated donor transplants. And what you see here, again, is feasibility in large numbers of patients. And maybe if you look at an important newer endpoint, incorporating graft versus host disease along with death and relapse, that composite endpoint may ultimately favor haplo, though again, it was smaller numbers of patients. When you look at this in the context of checkpoint inhibitors, so again, these are data put together by Reed Merriman, over 200 patients. What this shows is, again, the feasibility of doing allogeneic transplant after patients have received checkpoint inhibitors, which is often the last line of therapy people have before we again start to think about the role of allogeneic transplant. And you can see in the curves on the right, maybe more encouraging progression-free survival, but again, important to look at the toxicity of the treatment as captured by graft versus host disease relapse-free survival. And you can see the 2-year event rate there is 47%. From a feasibility standpoint, the relapse rate looks lower and encouraging. These are largely responding patients. And there is that signal of toxicity where acute graft versus host disease may seem to be a bit higher than what we've seen with traditional studies. Though again, it's always complicated in these analyses when you have a mixed collection of transplant procedures and transplant donors in terms of how things get done. And I'll just highlight here, we presented some data from EHA because most of that other experience was with nivolumab. There's some data with pembrolizumab here looking at 57 patients with classical Hodgkin's lymphoma, as well as 5 patients with primary mediastinal and 8 with other heme malignancies, showing a very similar signal in terms of favorable disease control, reasonable overall survival, what appears to be like maybe a little more acute graft versus host disease than what you would expect, but showing feasibility and safety of allografting in this setting. And so when you look at this, in context, what can we conclude? So the outcomes look favorable. You see lower rates of relapse compared to historical data, but the timing here And what you do is really the important question. And so certainly what's published out there in the literature is you ideally want to wait 3 months before PD-1 exposure before thinking about an allograft. But there's a lot of questions here around disease biology. What is the checkpoint inhibitor doing? How may that influence those cells when they're infused? How important is disease control in all of this beyond what the checkpoint inhibitor may be doing with biology? Or again, as the transplanters continue to improve what they do with additional maneuvers, how much of that change in how transplants are done are really driving outcome as well as patient selection. So the challenges for the clinicians, it becomes a big discussion for patients. Do you continue on the checkpoint inhibitor if it's working, or if patients achieve a CR, or do you wait until progression? And I'll admit, in our group, our general approach is to try and get as much mileage out of the checkpoint inhibitor that we can. And it still is a rarer patient for our practice that will go forward towards allo. And you're looking for that ideal patient that they'll be safe, they'll have a good donor, you'll have good experience in terms of how this gets done, but very important to individualize decision-making in this setting. In the last few minutes, I'm just going to highlight older patients with relapsed refractory Hodgkin's lymphoma, just to highlight again one of the big experiences now published almost 10 years ago from the German from the German Hodgkin study group. A small number of patients, and that reflects the rarity of data here. So even for the Germans, a little over 100 patients over the age of 60. And again, when you look at overall survival, again, not very encouraging and not what we tend to see associated typically with outcomes in Hodgkin's lymphoma. So in this data set, they looked at multiple strategies, whether patients were eligible for intensive chemotherapy, ended up getting a more conventional dose approach or salvage radiation or palliative approaches. And so when you look at outcomes here, again, the numbers were roughly split, a third, a third, a third in terms of the treatments. They were able to construct a risk group looking at fairly simple clinical factors, the presence of early relapse defined as within a year, advanced stage disease, or the presence of anemia. And you can see at the top there, the patients that had higher risk really had an inferior survival, whereas those lower risk groups, which had less than 2 factors, so only one of those factors or 0, tended to have a more favorable outcome. The curves on the bottom, broken down into low and high risk, really show that there's, in this data set, no advantage for intensified treatment above the age of 60, some of whom were patients that had platinum-containing regimens and might have gone on to a transplant. And so it sort of leads to the question about what are we accomplishing in potentially older patients that have undergone transplant. So I'll highlight one of our data sets that's a little old now, but does show the feasibility of stem cell transplants in older patients. And so we were looking at this in a stepwise manner. We initially looked at this between the age of 60 and 65 and show feasibility in comparison to our younger patients for favorable outcome. Again, we're obviously selecting who we transplant. These were all patients that had responses to platinum-containing chemotherapy. And over time, we've increased our upper age limit initially up to 70. And now we've really moved to a fitness-based eligibility for transplant. And we have data that will hopefully be updated soon and available for you to see, looking at how this has played out over time with more patients and a more broad age criterion. So salvage therapies, unfortunately, are not that well studied. When you look at recent series, the challenge is all of these patients get incorporated into the bigger data sets that are typically younger. And so there is some experience with gemcitabine Doxil, with BGEV, and with novel regimens, BV-Benda or BV-Nivo, where the upper age limit of patients in those studies does hit 70 or even potentially 80, but we really don't know how their individual outcome may go. And so the optimal approach here, how do we deal with elderly patients? It's important to recognize if this patient may be curative or not. I think in a selected group of those patients, a salvage and transplant can be considered and appears to be feasible and safe. Very little data looking at novel combinations in this patient population as well. And when you're looking at, again, the checkpoint inhibitor data or with BV, again, just remember that comparison may favor the checkpoint inhibitor. We don't have a lot of data looking at biology and how that may be different in older patients. But from a tolerability standpoint, I think it works fairly well. You may be able to give the drugs less frequently based on some of the data from solid tumor. which may be of benefit if older patients really have a tough time getting back and forth. But again, room for lots of data to better inform these decisions. And so to conclude, what I hope I've showed you in the past few minutes is that we've seen the evolution of therapy here with the incorporation of novel therapy and how that has really changed the field of relapsed refractory classical Hodgkin's lymphoma. Getting them into the curative setting, the data are more limited, and we struggle because of a lack of randomized trials. The efficacy does appear to be there, though. The toxicity signal does not appear to be a big one, and we'll need to see how that goes moving forward. The data around allotransplants, I think there's very good clinical questions there, and that is very much an individual decision-making conversation to be had with patients. Older patients, I think we need higher quality data. And again, I'll drive the point home. We need prospective and randomized trials, because Hodgkin's has been a great example where we've been able to really move the field forward from frontline and beyond with the incorporation of well-designed studies. And so with that, I'll stop, and thank you very much for your attention.
Thank you, Dr. Kuruvilla. That was very, very interesting talk. We have some friends here. I'd like to ask some questions to Dr. Kuruvilla. Yes, Ashish, go ahead.
Dr. Kuruvilla, thank you for a wonderful talk. Just a couple of questions. What is the role of radiation in salvage setting? Like if the patient has relapsed, what is the role of radiation?
Okay, so I guess there's a couple of questions that you could embed in there, Ashish. So firstly, looking at a patient in the relapse refractory setting that might be in the transplant category. So 2 points. So firstly, many groups have used post-transplant consolidation with radiation in patients that have achieved a remission, bulky sites, or localized disease. Again, no level 1 evidence, but very practical in terms of what we do. And a good proportion of the patients at Princess Margaret over time have had that. Salvage radiation as an approach pre-transplant. So again, our group historically showed that when you give mediastinal radiation before a transplant with old techniques, it didn't work very well. But if you're able to give IMRT techniques, it can be done safely. And certainly patients with localized disease can be considered for salvage radiation consolidated with a transplant and appear to have relatively good outcome. For the non-curative intent patient from a salvage and transplant perspective, salvage radiotherapy has long been used in patients. There is a proportion of patients, and again, our group has published this, our radiation group has had a lot of experience, and can show that there is, again, the potential for a subset with a salvage radiation approach to potentially have durable remissions. I'd say with the advent of novel therapy, radiotherapy has been largely de-emphasized over time, as it has been de-emphasized more and more over the frontline setting. And so it's a good reminder for clinicians out there that radiation remains a very active therapy. It's also very cost effective. It's also well tolerated. And so I think there is room, certainly in that setting, to think about using radiation, and important to remind people of that.
Another question that I have was that with the increasing use of rituximab in the frontline setting, what would be happening probably to the in future with regards to the salvage treatment? Because I think if pembrolizumab also moves to frontline, we will have really very few options again in the relapse setting.
It's a key question, right? So you're right. Again, you hope the cure rate improves substantially, and we have fewer patients that we have to deal with, and that's the success. Give the treatment once, but those of us that get stuck having to manage patients in the relapse refractory setting, you're using good options, right? So firstly, maybe the idea of retreatment. So there's very little data looking at brentuximab and retreatment, but it does speak to the idea that CD30 tends to be present, and that the feasibility is there to retreat people, though again, funding access may be an issue. And we know that toxicity, again, with myelosuppression, but particularly neuropathy, may be a concern. It certainly doesn't look appealing if patients are primary refractory to a regimen that incorporates BV. And so we have to be clear about that. That might be the patient population you'll definitely avoid. Looking at checkpoint inhibitors, it's a little more interesting in that there may be that idea that checkpoint inhibitors in combination may sensitize, and so retreatment might be more feasible, where again, you don't tend to see cumulative toxicity. But again, certainly for environments like ours, from a funding standpoint, you'd need a good design study that has had patients previously exposed and retreated before, a payer in Canada would even be willing to consider it. So I think there's the challenge there, though I think scientifically it's potentially more appealing for that reason, as I outlined earlier.
Yes, Ashish, any more?
Yeah, one more question actually. That was that what is the current role of CAR T in Hodgkin's, like the CD30 directed CAR T? Where does it stand?
So still investigational. I think that's the easy way to put it. When you look at the early data, we haven't been, as overwhelmed, I think, by the data that we saw in DLBCL, obviously, and again, the activity may not look as good. So how much of the platform do you need to modify to get there? But, maybe leave you again with sort of a philosophic comment. When you think about the differences here, Hodgkin's is a tumor of microenvironment by nature. It's a very immunosuppressive tumor microenvironment. So there's probably more of a hurdle immunologically for CAR T to deal with than in comparison to what we see in DLBCL and its variants, right? So I think, again, lots of people are still working on that platform. Might it be dealt with a combination approach with a checkpoint inhibitor going in? Should the lymphodepletion be modified? I think there's lots of things that can be asked, even, how the cells may be modified as well. But hopefully work in progress.
Thank you.
Thank you, Ashish. Krishna?
Thank you very much for a brilliant talk. So my question is, you put up a slide for allotransplant patients, the chemosensitive ones, they do better than the chemorefractory ones, if I understand correctly.
Yep.
So if you have a situation, a patient who has not responded to the second line salvage chemotherapy, and he responds to brentuximab plus minus checkpoint inhibitor, and he has become SPET CR, do you follow that patient up with an autologous transplant or an allogeneic transplant?
Yeah, so in a patient that you were initially heading towards transplant, might receive second line therapy, not responds to a third line therapy, the goal there, I think, is definitely an autologous transplant. So we know that those patients, if they achieve a CR, they have a very good outcome. Now, the data from Memorial in New York would say their outcome after a third line regimen, if they achieve a CR, is basically identical to if you achieve a CR second line. I think that's maybe a little too good, but I think, we have a lot of experience with any other regimen. If they get into a response with a third line consolidating with an auto, the outcome looks pretty good. I think then, to me, when you get beyond third line, should you be thinking about a transplant if they respond to something else? That's an unknown question. And I think more about, an allograft type patient is someone who might have had the autograft after achieving a couple of things or after responding to something. If they progress post-auto, how do you think about that? And it firstly will depend on what they've had before and what you're able to access post-auto. And then again, a lot of patient characteristics as well.
So the other question I have is, in your practice, which group of patient you definitely refer for an allo? Is there any indication like that?
Yeah, so this is very much a difficult choice, right? And I'll say in our group, we all have a slightly different approach about what we think about allo. To me, I've largely put my faith in novel drugs because I think we've seen how they've changed. I think the challenges with allo in particular are you will have toxicity events leading to death potentially in 20% of patients within the first year, and you don't get those patients back to do something else, right? So that being said, firstly, it has to be a patient that is very open to the idea of that type of toxicity. And then I would say, I want someone who's young. I want someone who has a good donor. And, you need a transplant team, obviously, that's very comfortable with doing allografts in lymphoma. And I think that, to me, is the three criteria. So most of the patients that I talk to about this, I think they have very fixed ideas about what they're interested in pursuing. And many of them do not like what they hear about the potential toxicity of an allotransplant.
Thank you. Thank you very much.
Thank you. Ashish?
One question that I had was that the initial data about BV maintenance came from studies post chemotherapy. So in those patients who have responded to, say, a combination of pembrolizumab with chemotherapy or pembrolizumab with BV, is there any role of giving maintenance BV?
That's a great question, right? So again, we tend to generalize data all of the time, right? And so I would say if you're in a situation where you can do what you want to do, to me, let's take a scenario where someone gets a platinum containing regimen, second line, doesn't respond, goes on to get BV or BV and a checkpoint inhibitor somehow responds, has a transplant. Should you give BV maintenance in that patient? Obviously no answer based on data. I think philosophically, I'd say that patient's a high-risk patient, and the data for maintenance derived from a high-risk patient population. And so I think if you're able to give it, it makes sense to give it. Ashish, I think the tough thing might be if you had someone that had received BV before, progressed, you give them something else, they respond, they're high risk that they had fit the Athera criteria based on prior therapy disease characteristics. Would you give them BV if you know that they'd failed BV before? That's where I'd probably say it makes less sense.
Okay. Dr. Chirag?
Yes. So about the age for auto transplant, what cutoff or what criteria do you use?
Yeah, so as I've mentioned, we historically had a strict numeric cutoff. It was initially 65, and then we expanded it to 70. Every time we've looked at our data, what we see is the non-relapse mortality creeps up a little bit. We see a bit of a decrement in progression-free survival, but we still do see the potential to cure patients and longer-term benefit. And since, again, the major cause of death in these people longer term is ultimately going to be lymphoma, the value still seems to be there. We haven't, since we formally got rid of our age cutoff, we've not actually looked at the data yet. And that was, probably about just before the pandemic started that we really gave up on age as a number. What I'll say is, as clinicians, we all play this game. You can clearly tell there's a patient who's 72 who looks like they should do fairly well, and you'll put them through standard organ function, et cetera. We all have criteria in our transplant programs, and they all pass. And if it's just that they're 72, that patient's probably going to go forward. But, in the patients that we struggle with, if they have a bit of organ dysfunction, if they have multiple medical issues, if there's, again, polypharmacy from a geriatric standpoint, I'll say we've got a very good geriatric oncology practice that we tend to see. They have assessments. So there's a scoring system that they can use to predict the toxicity of combination chemotherapy approaches. And we'll often get some of that assessment to help make us try to be a little more objective about making the decision. But we'll look at that data and, hopefully we'll continue to see value in doing this without the number.
Yeah, I think we were using cutoff of kind of 60. So this is a good information. And there are people who are 65 and looking good where we could push for transplant. The second one is that you did mention a little bit about it, the need for CR versus PR before transplant. And I see a fair number of second opinions where patients have had PR and not offer transplant. The transplant center kept pushing for more chemotherapy to get CR, and then ultimately something happened, because of continued treatment, and never could get into transplant. So if you can elaborate on the need for CR versus PR.
Yeah, so that's exactly the thing that our group worries about. And so, our approach had always been, in a patient that achieves a PR, they should go ahead and have a transplant because, you're totally correct. the potential for additional toxicity, infection, whatever, may limit the ability to get to definitive therapy, and you've already achieved response. In contrast, if you have that patient that basically has stable disease, or the PR that looks almost like stable disease, then I think that's really where a switch of regimen is going to be of benefit. And so that's generally how we've tried to look at this. So the PD patient, it's obvious. The patient that looks like stable disease, again, with bidimensional measurements and PET imaging, definitely switch. And I think the PR for us is still worth moving forward. And as I said, you just kind of want to get to definitive treatment, I think, as quickly as you can. And in the PR patient, I think that's, again, where you might think maintenance with BV, if that's the type of patient that you could access it for, it is the right thing to do. And you can still address the disease on the back end, just like consolidative radiation in a patient that you can't think of getting BV. If they're in a PR going in, that's the other patient population we like to consolidate with radiotherapy to that site.
Would you do a maintenance checkpoint inhibitor post-transplant instead of BV?
I would if there was level 1 evidence behind it, I guess is the answer. So again, Philippe Armand and the group at Dana-Farber has published a single arm trial that really speaks to feasibility. It looks good. Immunologically, there may be something very interesting there to incorporate that post-transplant, certainly. But to me, that's a tough sell. It's hard to understand the benefits. And in this world, you need to do a really good comparison now against BV maintenance. And so that would be, I think, a difficult trial to execute.
I mean, because I think that it may be easier to tolerate, at least, because we find BV very difficult to tolerate post-transplant with severe myelosuppression, where...
Yeah, no, I totally agree. I mean, it would be, that would be the sort of study, given the numbers, when you look at what the PFS would look like in the control arm and how you would have to structure it, that would be a fairly big undertaking for a company to do as a confirmatory trial or as a randomized study. But, as a clinician, you're totally right. It would be a much easier drug to use and to work with, but we just, we don't have evidence to do it, right? So that course of therapy would be, too expensive for us to use.
And with checkpoint inhibitors, now we have patients asking, they want to avoid transplant. Now, for whatever reasons, if medical reason or otherwise, if you were to avoid transplant, how long should you give checkpoint inhibitor?
Yeah, so, a tough question. When you look at the data, and say, let's be evidence-based about what we want to do. So conveniently, pembrolizumab, the whole program gave us an answer. Every pembrolizumab study, it's 2 years and stop. So there is a fixed duration of therapy. So I like that because it comes to an end. Conversely, you can give nivolumab indefinitely as per protocol. There was one cohort in Checkmate 205 that looked at if you achieved a CR to then discontinue after 2 years. And so again, you're going to see some follow-up data from that eventually. I think, for a lot of patients, it's the fear of relapse, as well as the clinician, the fear of relapse on the Nivo program. But I think increasingly, the majority are going to have an event before, because that's just what the median PFS looks like. And in that minority that, continue longer term, I've done both. I've had patients that want to stop. But when I explain the lack of data on that program, most of them tend to continue. And if I have to pick now, I'm probably favoring Pembro because it has a fixed duration program. So when you're stopping. And I also like the convenience, again, based on the solid tumor data, of being able to move from Q3 to Q6 weekly dosing, which is far more convenient.
The last question, lenalidomide, we have used as salvage or, after multiple relapse. We don't hear that data anymore. Anything on that?
Yeah, so that was the first trial I ran as an investigator-sponsored study myself, was to do a lens study in Hodgkin's lymphoma, and the activity, unfortunately, was pretty modest. The tough thing I think there is when you think of the biology, there might be a very good story to look at it in combination with other things. But you know, might just say it's less flavor of the month these days. It's now a generic drug. That being said, that should allow investigators to work with it a little more easily. And so, you know, I hope I would see something that's going to be a little more biologically rational in terms of how you would approach the drug, but it will need to be given in combination.
Okay. Thank you, Dr. Anu.
Looks like you're muted.
We can't hear you, Anu. Okay, we'll come back to you, Dr. Ashish.
So Dr. John, actually in resource constrained settings like India, continuing Pembro for 2 years is really an impractical option for most of the patients. So taking a cue from solid tumors where it has been shown that even limited number of doses are quite as effective as compared to a prolonged duration of therapy. So are there any studies that are looking at the duration of the immunotherapy, say lesser duration of immunotherapy with pembrolizumab?
Not that I'm aware of, right? And so obviously, you know, the companies are not really going to be keen to sponsor studies that look at much shorter durations of therapy. I mean, what I would say is I think the appeal might be, you know, firstly, if one could give a combination approach, you might be able to really reduce the amount of treatments that you give. Firstly, and so again, the example I might give you is when we did the phase 1 study, which was investigator sponsored, looking at brentuximab in combination with bendamustine. That was a fixed duration program where we would give 6 cycles of therapy and stop. And so you wouldn't have to give 16 doses potentially of brentuximab. We saw a much higher CR rate for a combination approach. Some of those patients are still in remission longer term. And so I'd hope to see that type of approach potentially being looked at. What you will see, there have been some publications, you know, from other countries around the world looking at, you know, more fixed duration of checkpoint inhibitor. Again, speaking to some feasibility, but it's really difficult to kind of conclude a lot without bigger numbers to know what to do. You know, I think pragmatically, you know, I hear you. I mean, no one wants to be spending that much on these drugs indefinitely. It just doesn't make sense. And so, you know, maybe practically as a clinician, it might be a little response adapted. And if you think you achieve CR at some point, you know, if it tends to happen, it doesn't tend to happen super late. And that maybe you consolidate that with a couple more doses and then stop. I think that would be a reasonable approach. Again, accepting that if the median PFS is still going to be about 13, 14 months, you know that half of your patients will be on the drug for a year and that will be it.
But in real life scenario, like those patients whom you had to stop due to toxicity, say for example, due to ICI mediated toxicity, have they done equally well or they tend to relapse?
You know, so I think the reports that are out there are a little mixed. I think they do speak to the potential for some lengthier duration of remission, but nothing, I think, astronomical. And so it'll be really, you know, what you do see in the longer term follow-up patients, at least that are on the studies, because they're easier to kind of have data on looking forward, is that you do see, again, much like with BV, much like with salvage radiotherapy, there are a subset of patients that tend to do well longer term, you know, even potentially on a fixed duration regimen. So I think the potential's there, but do I expect it to be a high proportion of patients? I don't think so, unfortunately.
Okay. Cool. Well, thank you.
Thank you. Any more questions for Dr. Kuruvilla? If there are none, then Dr. Kuruvilla, thank you.
Yeah.
Yes.
One question.
Yeah, go ahead.
Dr. Kuruvilla, you mentioned about the radiotherapy. I had some issue with the net then, but you know, we have used it in some patients in salvage. And can you elaborate on the concerns with the side effect that, you know, is it so bad that, you know, we kind of brushed it aside? And I know that when we don't have expensive drugs possible, at least there it may be worth.
Yeah. Yeah. So what I would say there, the older teaching and, what I learned when I was doing my fellowship was that with older radiation delivery, and again, the majority of these patients with Hodgkin's, you're worried about disease that's in the mediastinum, right? So there was a very high rate of pulmonary toxicity when they went on to receive high dose therapy and a transplant. Now, again, the early data that looked at this a little systematically, there was actually a phase 1 type study that was done when Laura Dawson was working in the US. And this was a regimen that used an IMRT-based techniques, so conformal radiation, and there was much lower rates of toxicity, and it was quite safe. And so, when our group saw that data, this again led to one philosophic question, which no one's talked about today, which is if you're not giving traditional chemotherapy, should people go on to have transplants if they respond to novel therapy or radiation or something else? Is it chemosensitive? What we now know is you respond to novel therapy, you respond to radiation, at least in Hodgkin's, you can have a transplant and you're equally likely to be cured than if you had responded to traditional chemotherapy. So old transplanters' dogma does not really appear to hold anymore. But the safety of using pre-transplant radiation, so if it's a neck node or an axillary node, or depending on the sites of disease, it's fairly safe. What our radiation doctors will say is if you have all of these other things that you may be able to access, do you want us to use salvage radiotherapy or not? And so they would kind of prefer not to. But the way I look at this is if it's a single site of progression after second line therapy, and it looks like you can easily encompass it in a radiation field safely, that's what I tend to do, because again, from a toxicity standpoint, it tends to go pretty easily.
Thank you.
Thank you. So Dr. Kuruvilla, thank you very much for sparing your time. It was very, very fantastic discussion.
All right. Well, very, very, very nice to see you all, and hopefully, some other time in Mumbai. Hopefully.
Yes. Thank you.
Thank you very much.
And the Indian colleagues, this brings us to an end of this 5 days long webinar. This was the last lecture. So have some relaxation now. Your evenings are free from tomorrow. Bye-bye.
Thank you, sir.